$146 billion in medical costs, over $80 billion when individuals who happen to have overweight or obesity status miss days because of their health. And sometimes what we call presenteeism, where an individual may be at work, but while they're there, they are not as productive as they could be. And this has cost a staggering $160 billion. And let's not forget about disability costs. That's another 30 billion, and workers' compensation, 5 billion. So, and this is all relative to individuals who are not obese or overweight. So I put this slide here. This is a study that was carried out between 2012 and 2021 that looked at any metabolic syndrome condition. So this looked at obesity, high cholesterol, hypertension, and diabetes. And what this study found was that death was the costliest event for that time period. 16,000 US dollars event year cost per person. And then when we look at complications, the cancer was the most expensive complication, ranging from $9,000 to over $11,000. And when we think about obesity and its potential cancers, we think about breast cancer, prostate cancer, colon cancer, gallbladder cancer, and we have to consider addressing these issues as far as metabolic syndrome to offset the effects and impacts. And the reason this is extremely important in the US is because a number of individuals who are obese in the US are being diagnosed earlier with these specific obesity-related cancers. So this is an urgency in the US. So rising premiums and cost-sharing employer plans. So for the general population of US workers, the family premium averaged well over $25,000 last year. And for a specific individual, almost $10,000. And this outpaces the wages the individuals make. So employers are increasingly trying to shift these costs to the workers through increased deductibles and coinsurance. And invariably, healthcare workers are impacted by this because we are in that standard workforce. It leads to affordability problems even when individuals are insured because they are effectively underinsured. And so when an individual is underinsured, what will they do? They will skip going to the doctor because they are concerned they can't pay like a copay, or they can't pay in the long run where costs aren't covered. So this leads to unmonitored and unmanaged diabetes, high cholesterol, hypertension, and these metabolic syndrome conditions are what we call silent killers, where you're not having symptoms, or you may have minimal symptoms, but in the end, when you have a significant outcome like a heart attack, a stroke, a diabetic foot infection, an amputation because of poorly controlled diabetes, that's the impact in the long-term effects of not managing these silent killers, or what I call them silent assassinators. So these are issues that we as healthcare workers need to make sure that we can stay on top of our health and making sure we're covered, but we're effectively underinsured in the US. And also what individuals do is they end up taking on more debt because they can't pay their bills. And so this leads to another delay in them following up timely with their providers. And so many employers have looked to kind of push employees into seeing specific doctors or providers, or receiving specific care that may not require such a high premium. So that it may lower the premium, but the patient or the employee has less opportunity to pick and choose who they really want to go to, or who the most a specialized person is who can take care of their medical conditions, specifically related to metabolic syndrome. So what about non-standard work arrangements? So our PRN workers or as need those workers who work as needed or part-time, our temporary workers or those who travel. So these individuals are prone to having lack of any type of insurance. So a lot of times individuals may have to pay out of pocket for any type of medical cost. Another thing that could happen is they have long waiting periods or there are gaps in between contracts and or limited options. And this does what? This delays their care and can result in worsening health status as a result of worsening conditions of metabolic syndrome, increased weight, ongoing poorly controlled blood sugars, and high blood pressures and high cholesterol. So what about the anti-obesity medication coverage in the US? So glucagon-like peptides or the GPL-1s, these are fairly new, and what they do is they work to decrease the craving, so people don't want to eat as much. So that is pretty effective for obesity and also can impact diabetes. But many of the plans, the healthcare plans we have in the US, don't include these GLP-1s specifically for obesity, or they make the criteria to get the medication extremely strict because they're pretty expensive. And coverage is more likely to be carried out if it's just prescribed for diabetes as opposed to just obesity or diabetes and obesity. But diabetes has to be in the equation for coverage to be most likely carried out. So plans that do cover the GLP-1s, they can have some barriers there. We have prior authorization, or there could be step therapy. Step therapy, the insurer may say, well, let's try this medication first. Have the doctor try this medication for the patient first. And if that doesn't work, try this one or try that one. And then this keeps going on and on until they say, okay, they've tried all these different medicines. Okay, let's give them a shot at the GLP-1s. So that's a big issue as far as delaying. Or they put caps where they're only paid so much a year for these types of medications. And we can only expect that this will get worse as time goes on and demand grows. So in the US, last August 2024, there were only 13 Medicaid programs that actually covered the GLP-1s, specifically for obesity and diabetes, I'll say. And for bariatric surgery, it gets a little complicated because an individual may have a BMI, let's say 45, and they're obese, but the insurance plan may also make an additional requirement where an individual has to have a comorbidity like diabetes, so obesity and diabetes, or obesity and high cholesterol. Otherwise, they won't cover the surgery. And that's another barrier, and that's just kind of waiting for the patient to get worse, unfortunately. Other requirements that sometimes that is noted with the insurance companies, they want to have some documentation. Make sure you have documentation of supervised weight loss attempts. So they want to make sure before they pay for anything, they have that information that the patient is trying to lose weight. And then unfortunately, sometimes these insurance plans just don't cover at all. So I have a map here of the United States, and what you can see here is there are only 13 states in the dark purple here that cover where the GLP-1s are covered for both diabetes and obesity. So it's 13 states out of the 50. And then the blue is where states that just cover this is all Medicaid, where states cover just the GLP-1s in diabetes, but not specifically for obesity. So as you can see, the large swath of states that are in gray, they don't have any specific coverage for the GLP-1s. So they're very expensive medications, and at this point, it's very new, so still relatively new. So it's something that it's hard to come by and hard and difficult at times for our patients to obtain access to. So what about wellness programs and surcharges? There are sometimes these discounts that are tied to specific metrics. So the HIPAA and the Affordable Care Act, they try to make sure that there isn't any type of discrimination, but there's a tie-up in cost and coverage. So unless a patient meets certain benchmarks, so a patient may have a BMI, I go again to this example, a BMI 45, and then over a certain time period, let's say the goal for coverage where the insurance company will pay will be 40. So they've dropped from 40 to 45, from 45 to 40. Okay, we'll cover. This is just an example. Unfortunately, sometimes the patients don't meet the benchmark and they have to pay out of pocket because they just didn't meet that benchmark where the insurance company would pay. So that can prompt, and that should prompt individuals to want to look into alternatives, which is obligated by the insurance companies. So these are some issues that unfortunately that the individuals when healthcare have to deal with. There are high out-of-pocket exposure for chronic care. We think about even when individuals are covered, there's still other things that it just builds up in the overall price and out-of-pocket costs for for a patient. So you still have to pay for routine hemoglobin A1Cs, your cholesterol panels, follow-up visits with the primary care or the specialist, and of course the pricey medications. So the rising employer premiums and pharmacy costs are also pushing employers to add utilization controls so they can make it, so unfortunately it's a little more difficult for individuals to get access to the GLP-1s, for example. So the network design can limit access to specialized obesity care. So these narrow or tiered networks can lower the premium, but it comes at a cost, a different cost, a physical health cost. So individuals may have to pay less, but they may not have where they can go to an obesity specialist, a board certified obesity specialist. They may, based on their insurance and lower premium, have to go to a non-specialist. They're not necessarily board certified in obesity, but nevertheless they can help. But that is not as optimal as far as the management for these individuals. In addition, access to accredited surgical centers is also restricted in some cases. And again, that leads to suboptimal management of obesity. You think about the bariatric surgery being limited to areas that don't really have that as a high specialization. Multidisciplinary programs are also restricted, and sometimes in these cases where sometimes there are lower premiums. So at Hopkins, we have an outpatient obesity clinic where it's multi-team managed. So there is a doctor who specializes in just obesity. That doctor tag teams with exercise physiologists that the patient sees, in addition to a psychologist in that clinic, and again, importantly, a nutritionist, a clinical nutritionist. So all these individuals work together as a multidisciplinary approach to help each individual patient. So multi-pronged approach. But when you pay these lower premiums, you miss this team approach effort because the insurance won't pay for it, which can unfortunately lead to worsening conditions because something's missed. Could be a psychological component missed, the nutritional component missed or delayed, and that causes, unfortunately, a poor outcome potential. So also look at our higher risk healthcare workers. So the employees who may not have very high salaries, they have lower salaries. compared to maybe some of the doctors and nurses in the hospital. So these are our aides, our support staff, our security staff or custodial team. And these individuals are more likely to be either part-time or temporary. And in such positions, it increases their risk of being either underinsured or uninsured. And hence, this can lead to unmonitored and unmanaged metabolic syndrome. And these coverage gaps can also happen for individuals who travel, for example, as once they go to one place and then they finish one stint, then they have to wait because they're not covered until they can get into another position of employment. Something else opens up, then they're covered again. So during all this, they can miss their insurance of medicines being covered, and so this leads to, unfortunately, worse health outcomes because they're not taking their medicines as they should be prescribed regularly. And also issues as far as surgery requirements, where let's say an individual can't get the necessary pre-op in preparation for a bariatric surgery because of delays in the pre-op because they don't have the insurance that's active. So HIPAA and the Affordable Care Act, these plans help to ensure that eligibility cannot be denied for individuals based on health factors like obesity. However, they can use these outcome-based wellness incentives with strict rules. And again, the narrow networks can have lower costs, but at another cost, a health cost, where there's a delay in the treatment, so the individuals get sicker because of lack of access or because of suboptimal management, where someone may not be an obesity specialist or diabetes specialist that is caring for the patient. So what can we do as healthcare workers in the US? At this point, we have to work together between the patients and the doctors. They have to work together, a patient and their doctor. Very tight collaboration. So during open enrollment, you have to be pretty proactive and aggressive to make sure that you check the plans to make sure that these GLP-1s for obesity are covered. And it's not just coverage for diabetes. You have to look at what prior authorization or step therapy looks like. These are potential barriers. So these are things you have to look into early on when it's open enrollment and time to start your insurance or select your insurance. And whether or not there's a separate pharmacy deductible. Also, for a bariatric surgery, it's important to check if the plan also adds a strict criteria for another medical condition in addition to a higher BMI. Are they also including that you have to have diabetes or high cholesterol in addition to your obesity before they'll carry out any type of surgery? So you want to make sure you know what your plan is before entering it. And if facing wellness surcharges, ask the plan for reasonable alternative standards, because all plans are required to offer alternatives. And I think some individuals don't know that, but it's important to know that they have to offer an alternative standard. And if we're looking at non-standard roles like the PRN or those travel employees, we have to look at plans for benefits that ensure continuity, so there isn't any dropped or gaps in between care. Okay, and this is a study I want to pull up because, like I told you, I'm a hospitalist, so I take care of patients in a hospital. This was a study that was actually published last year in the Journal of Brown Hospital Medicine. I really like this study because it showed there was actually looked to be some progress. So some years ago, at our hospital, we carried out a study where we looked at the number of times individuals, the provider documented obesity. And we actually found that the documentation of obesity for patients who are obese was extremely low. It was like in the teen or 10%, 15% documentation. This was several years ago. But this current study that was carried out, study was done in the state of Utah, and it's a system there, and it looked like they had up to 60% of documentation of obesity when appropriate, and this is a marked improvement, much better than a previous, and it could be why we see such a great improvement. It could be the improvement over the years of the electronic healthcare system. So everything is a little more streamlined. So that carries over the patient and verified on a rehospitalization that this patient may have obesity. The downside is over the years, there hasn't been much of a change as far as what to do after a patient is diagnosed with obesity. After you have the awareness, you've increased awareness about obesity, they're documenting obesity. They noticed in their study there weren't many referrals to weight loss clinics when the patient left the hospital. In addition, prescribing GLP-1 inhibitors was extremely low. And if you think about it, and a little bit of what I talked about was the GLP-1s aren't covered for Medicaid in many of the states. So that could be a reason. I think Utah is one of the areas as well. So that could be a problem. The number of clinics, weight loss clinics in Utah, not sure, but not only the number, but the coverage, the insurance coverage. So that could be an issue. So significant barriers, long way to go. Okay, and I want to thank you for giving me the opportunity to talk at this conference. It's the 5th International Conference. Very happy to be here. Healthcare workers, we have to make sure that we're taking care of ourselves. I know this was a U.S. perspective, but at the same time, we have to do what we can globally to make sure that we're in the best condition to take care of our patients. We have to be very proactive. Metabolic syndrome is a silent killer, and we have to be on top of it because it can cause long-term consequences and even kill us. So thank you so much. And this is my email, and you can feel free to contact me with questions, or I can take questions if time permits.
Thank you very much for the presentation, Dr. Harris. So, Dr. Harris, can you look at this Zoom? Can you see us?
Yes.
Yes, Dr. Harris. So
yes, I can see you. Yes, I can see you. Yes.
Dr. Harris, so today we are in a different room with the previous event. We are now in the new room. Previously, we are in the lecture room. So in this conference, we are in the auditorium. And then Dr. Harris, so the question and answer session will start after one presentation. So will you stand by in Zoom?
Yes, I'll be here.
Yes, thank you very much, Dr. Harris, for your time and for all participants in this room. So for the person who will questioning to the speaker will receive the souvenir from the committee. Ya, jadi siapa yang mau bertanya ditahan dulu karena sesi tanya jawab akan dimulai setelah presentasi berikutnya ya. Ada 2 presentasi dulu. Dan yang bertanya akan mendapatkan souvenir menarik dari panitia. Okay, ladies and gentlemen, I will move over there again. Please wait a minute to start a new session. Ladies and gentlemen, our second expert, we already familiar with. Let me read his curriculum vitae first. Dr. Febri Endra Budi Setiawan, MKes, FISPH, FISCM, is an associate professor, lecturer, and head of Laboratory and Department of Public Health Medical Faculty, University Muhammadiyah Malang. Dr. Febri has more than 40 publication, 30 book, and until today, with more than 1,500 citation, and his research area are public health and occupational health. Ladies and gentlemen, please warmly welcome our expert, Dr. Febri Endra Budi Setiawan, MKes FI, SPH, FISCM. Monggo Dr. Febri. Monggo Dr. Febri, di mimbar boleh, di sofa boleh, jalan-jalan juga boleh. Karena kita sudah sangat familiar dengan Dr. Febri, Kaleb Departemen IKM kita. Dan untuk mungkin ada mahasiswa yang ada di sini sudah sangat familiar ya, kalau Dr. Febri biasanya sukanya jalan-jalan. Tapi monggo dokter bisa di atas sini atau di mimbar dipersilakan. Slide-nya sudah ya Mas Zainal ya? Baik, sampun. Baik, kepada Dr. Febri dengan hormat waktu dan tempat kami persilakan.
Oke, thank you Dr. Putri Damayanti, Honorable Dean Faculty of Medicine, University of Muhammadiyah Malang, Dr. Medi Setiawan, SPPD Vinasim, Vice Dean First 2, 3, and my partner lecturer in Faculty of Medicine, University of Muhammadiyah Malang, especially Chairman in conference, Dr. Anissa. She is assignment itu discussion about dynamic of healthcare services for worker under the BPJS ketenagakerjaan system. Okay, Honorable Speaker, Mr. Matthew Harris from Baltimore, right now and 9 or 10 p.m. in Baltimore. This is Gailin Manalang from Philippines, and Mr. Febi Dwi Rahmadi from Griffith University. Thank you to committee give me opportunity to presenting then about healthcare services for worker and financing about BPJS ketenagakerjaan system. I'm sorry, I'm presenting in Indonesian and in English. Dr. Rubayat call gado-gado language. Okay. Miss Manalang must be invited to eat to gado-gado. Very nice, very yummy. Okay. Oke, rekan-rekan semua, problem pelayanan kesehatan untuk pekerja itu tidak simple, it's very complicated, very complicated. Semua aturan jelas, the regulation is clear, but implementation not clear. I think not in Indonesian, the all countries. Regulation clear, undang-undang, law, government regulation is clear, but implementation not clear. Oke, slide. Nah, pembiayaan kesehatan itu menjadi hal yang sangat penting ya di dalam pelayanan kesehatan. Menjadi kunci dalam sistem pelayanan kesehatan. Ya. Orang bilang no money no action. Tidak ada uang, tidak ada action. Tapi di kesehatan tidak berlaku. Kalau kita tidak melakukan pelayanan di saat kondisi emergensi, pintu penjara di depan kita. Ya, ini yang harus rekan-rekan sadari, begitu berbedanya kita. di sektor kesehatan. Next. Slide, please. Ya. In general, health financing for work ada 3 kategori. The first, fee for service, out of the pocket. Kita membayar sendiri pembiayaan kesehatan yang kita lakukan. Tidak ada yang menanggung adalah diri kita sendiri. Saya rasa di semua negara ada ini. Di all countries ada. Ya. Yang kedua, reimbursement. Kita bayar, kita klaim dengan syarat-syarat tertentu, ya, dengan besaran yang tertentu. Ada rule-nya, ada aturannya. Dan ketiga, kita menggunakan health insurance. Insurance base, baik itu private ataupun social insurance. Ya. Saat ini untuk Indonesia, in Indonesia, more than 54 million people tergabung di dalam BPJS Ketenagakerjaan. And data at February 2023. Artinya apa? Yang tergabung dari seluruh pekerja di Indonesia tidak lebih dari 50%. Ya, pekerja kita lebih kurang 200 juta. Antara 180 hingga 200 juta. Penduduk kita 280 million. Nah, sehingga pembiayaan pertama dan kedua masih cukup tinggi. Dan kita tahu bahwa biaya kesehatan itu bukan biaya yang kecil, tapi biaya yang cukup besar. Maka untuk itu di semua negara, tadi dikatakan Dr. Matthew, bahwa di Amerika pun ada batasan-batasan, ada hal yang harus dikerjakan dan itu lebih ke arah pada insurance base. I don't know in Filipina, I think is insurance before service reimbursement. Ya, next. Indonesia ada 2 logo yang penting di dalam pelayanan pembiayaan kesehatan untuk pekerja yang dikelola oleh pemerintah. Social or government health insurance, we call JAM Sostek before 2014, but after 2014 we call BPJS Kesehatan, and then they are called BP Jam Sostek. Mereka tidak mau sekarang disebut BPJS Ketenagakerjaan. Sejak 2021 mereka minta dipanggil BP Jam Sostek. Ya, karena kalau BPJS Ketenagakerjaan dalam bahasa Jepangnya jumbuh ya. Ya, Dr. Putri ya. Jumbuh dengan BPJS Kesehatan. Nah, karena sama-sama ke-nya. So, they want to call BP Jam Sostek. Next. Perjalanan yang panjang dari BPJS Ketenagakerjaan. Next slide. Ya. Dimulai setelah merdeka 1947. Sudah diformulasikan PT Jam Sostek dengan basic undang-undang, dasarnya adalah Undang-Undang Nomor 33 Tahun 47. Di sini menyatakan bahwa di dalam undang-undang setiap pekerja harus mendapatkan pelayanan kesehatan dan juga harus kita fokus pada keselamatan dan kesehatan kerja. Ya, diperkuat di Undang-Undang Nomor 2 Tahun 51. Indonesia baru merdeka 6 tahun. Ya. Kemudian ini diperkuat lagi di tahun 69 dengan Undang-Undang Nomor 14, ya, bahwa semakin transparansinya asuransi sosial. Ya. Langsung melompat di tahun 77, ya, disahkannya peraturan pemerintah nomor 33 tahun 77 tentang implementasi dari asuransi sosial. Saat itu kemudian diluncurlah program Social Insurance Program for Worker, ASTEC. Kemudian dibentuklah PT ASTEC dan menjadi mandatori, wajib setiap perusahaan harus mengasuransikan pekerjanya di PT ASTEC. Nah, perjalanan penting dimulai pada tahun 1992. Di sini mulai dikenalkan, lebih ditajamkan tentang Social Insurance Program for Worker, tentang jaminan sosial tenaga kerja. Sudah disampaikan apa yang harus ditanggung, harus dikerjakan oleh asuransi tersebut. Adalah jaminan kecelakaan kerja, work accident security, jaminan kematian, jaminan hari tua, dan jaminan pelayanan kesehatan. Highlight situ adalah healthcare security. Ya, nanti akan kita bahas itu. Nah, berdasarkan aturan pemerintah, peraturan pemerintah nomor 36 1995, maka PT Jam Sostek, ya, itu ditunjuk untuk menyelenggarakan pelayanan jam sostek di Indonesia. Nah, jadi saat itu logo yang tadi pertama, jam sostek, ya, ditunjuk nyata, ada aturannya. Next, Mas Zainal. Nah, mulailah gonjang ganjing. Nah, gonjang ganjing itu apa ya? Gempa bumi, earthquake. Gonjang ganjing muncul Undang-Undang Nomor 40 tahun 2004, Jaminan Sosial, Sistem Jaminan Sosial Nasional. Nah, pemerintah saat itu mewajibkan mandatori kepada seluruh penduduk di Indonesia yang saat itu 2004 jumlahnya mungkin sudah 200 juta untuk memiliki jaminan sosial nasional. Kenapa begitu? Karena ternyata banyak penduduk itu yang tidak bisa mengakses khususnya pelayanan kesehatan. Maka wajib. Siapa yang wajib? Semua yang merasa punya identitas Indonesia dan orang asing yang tinggal 6 bulan secara berturut-turut. Harus, wajib. Ya, pemain bola main di divisi utama menggunakan harus pakai ikut sistem jaminan sosial nasional. Nah, jaminannya ada itu. Nah, yang pertama di atas adalah jaminan pelayanan kesehatan, healthcare security. Yang sebelumnya tadi di tahun 92 itu di nomor paling bawah, yang diutamakan adalah jaminan kecelakaan kerja karena berbicara adalah worker, pekerja saat itu. Sekarang kita berbicara penduduk, yang utama adalah pelayanan kesehatan. Baru kemudian 4 jaminan yang lain. Work accident security, death security, old age security, and pension security. Nah, ini menarik. Ada jaminan pensiun. Saya tidak tahu di, I don't know in Filipina, pension security. Yes. Di Amerika saya tidak tahu. Tapi di Indonesia, kenapa ada jaminan pensiun di Indonesia? Karena ternyata banyak sekali ya orang-orang tua tidak punya kemampuan dan tidak apa-apa, tidak bisa apa-apa, sakit sendirian di rumah sampai meninggal. Oke. Diperjelas di tahun 2011. Pemerintah membagi dengan tegas ya, dengan Undang-Undang Nomor 24 tahun 2011 ada BPJS Kesehatan dan BPJS Ketenagakerjaan. Nah, BPJS Kesehatan ini mutlak mengawal tentang healthcare security. Sedangkan BPJS Ketenagakerjaan mengawal tentang 4 security yang lain. Ya. Kemudian Undang-Undang tahun 2004 itu secara aturan hukum harus berlaku paling lambat 10 tahun harus diimplementasikan. Disinilah mulai implementasi gonjang-ganjing yang tidak gampang, teman-teman. Ya, 2014 PT Jam Sostek yang tahun 1992 disahkan bertransformasi menjadi BPJS Ketenagakerjaan. Ya, hari ini saya tidak akan bahas BPJS Kesehatan. Dengan 3 hal yang di-cover oleh Social Security Agency for Employment. Work accident, death security, dan old age security. 3. Pensiun? No, belum. Baru setahun kemudian BPJS Ketenagakerjaan memberlakukan satu program baru, yaitu adalah pension security. Ya, jadi BPJS Ketenagakerjaan 2014 tidak sama sekali menghandle pelayanan kesehatan kecuali ya akibat kecelakaan kerja. Ini sangat menarik. Oke, next. Dalam perjalanannya, next slide. BPJS Kesehatan dalam perjalanan BPJS Kesehatan seperti gelombang, protes sana sini, wah klaim dikurangin, ditolak dan lain-lain. Ya, nah nanti kita akan diskusikan. Nah, 4 hal yang dikelola oleh BPJS Ketenagakerjaan, work accident security, death security, ya, dan healthcare security sama sekali tidak disentuh oleh BPJS Ketenagakerjaan. Dan ini menjadi mutlak, ya, mutlak tanggung jawab dari BPJS Kesehatan. Ya, next slide. Program-program di dalam BPJS Ketenagakerjaan sudah jelas. Kalau kita kecelakaan kerja, maka akibat dari kecelakaan kerja itu ditanggung. Seperti apa batasan kecelakaan kerja? Semua akibat ruda paksa yang tidak disengaja tentunya, yang terjadi menuju tempat bekerja, di tempat kerja, sampai pulang, go home, ke rumah, ya, dengan jalan yang wajar, itu ditanggung. Termasuk tugas keluar selama itu ada surat perintah, surat tugas, maka jika terjadi insiden, eksiden, maka tanggung jawab pembiayaan yang terkait dengan gangguan kesehatan ada di BPJS Ketenagakerjaan. Selama ada surat tugas. Jadi kalau misalnya Dr. Rubayat ditugaskan ke Filipina. Dr. Rubayat makan seafood, gatel di sana. Nah, itu gangguan penyakit akibat kerja. Ditanggung oleh BPJS Ketenagakerjaan. Tapi kalau Dr. Rubayat biasanya dibayari, tidak akan gatel. Biasa, sama Dr. Rubayat itu selalu begitu ya, jangan kaget. Nah, jadi tidak ada masalah. Jadi tidak harus di tempat kerja, kecelakaan kerja itu. Asal ada surat tugas, surat perintah. Ya, nyata, jelas. Nah, kemudian banyak lagi hal-hal yang di cover terkait dengan kecelakaan kerja. Termasuk santunan, selama belum bisa bekerja, keluarga tersebut dapat santunan pembiayaan. Karena dia nggak bisa bekerja, artinya apa? Gaji harus dibayar, honor harus dibayar. Ya, nanti mau masuk kerja, ada program return to work. Ya, kita akan menilai assessment, layak nggak bekerja. Kalau nggak layak, harus dipindah, atau memang sudah tidak bisa bekerja lagi, maka harus dipikirkan program pensiun. Ya, kalau ternyata kecelakaan kerja itu meninggal, sudah ada aturannya. Ya, meninggal karena dalam proses kecelakaan kerja. Ya, berbeda dengan kalau dia sakit meninggal meskipun dia bekerja, berbeda. Ya, kecelakaan, berangkat, pulang, kecelakaan, meninggal. Nah, itu termasuk meninggal karena kecelakaan kerja. Dia dapat hak ini. Ya, 85 gaji. Ya. Tapi dengan catatan, sudah ada aturannya sekian bulan bekerja. Bukan kalau hari ini bekerja, hari kecelakaan dapat 48, enggak. Ada rule-nya. Oke. Ya, lanjut. Nah, ini kematian sudah jelas, santunan kematian, ya, kompensasi sampai 24 bulan, kemudian beasiswa untuk keluarganya. Ya, ini kalau dia sudah bekerja minimal 5 tahun, ya. Jadi putra putrinya yang sekolah itu ditanggung oleh BPJS Ketenagakerjaan. Ini ada aturannya. Kemudian hari tua, ya kalau sudah hari tua termasuk pensiun nanti akan mendapatkan cash money. Oke, next. Nah, ini kita mulai di sini keruwetannya. Kita akan berbicara red box, kotak merah ini. Ya. Jadi seperti saya katakan tadi, ruang lingkup kecelakaan kerja adalah pada saat dia bekerja. Problemnya adalah bagaimana dengan occupational disease. Occupational disease jelas penyakit yang disebabkan karena pekerjaan atau penyakit yang sebabnya ada di tempat kita bekerja. Penyakit, masalah kesehatan, ya, sebabnya di tempat kerja karena pekerjaan. Mutlak ini. Nah, pada BPJS Kesehatan, next slide, ada 21 disease not covered by BPJS Kesehatan. Ya, ya, kosmetik jelas gitu ya, kemudian kriminal gitu ya, pengobatan tradisional, Anda mau beli jamu, traditional medicine, beli jamu yang enggak ditanggung. Ya. Kemudian KB, nah, ya, banyak sekali yang tidak ditanggung. Oke, next. Nah, disinilah kita mulai lihat. Ya. Kalau kemudian penyakit akibat kerja, baik itu langsung karena kecelakaan, maka saat ini BPJS Kesehatan tidak menanggung penyakit tersebut, pembiayaan. Nah, inilah ruwetnya untuk masyarakat. Ya. Aturan regulasi clear, jelas, tapi begitu masyarakat sakit, didiagnosis dermatitis kontak iritan, diketahui dia adalah occupational disease, tagihan dermatovenerologi nggak akan cair. Nggak akan cair. Akan dikembalikan dan diminta untuk ditagihkan ke BPJS Ketenagakerjaan. Simple. Kalau kita pahami itu. Tapi kalau kita nggak pahami, yang ada apa? Bertengkar di rumah sakit. Yang ada apa? Saling menyalahkan. BPJS Kesehatan tidak profesional dan lain-lain. Padahal aturannya jelas. Ya, kadang-kadang kita sebagai dokter tidak mau melihat. Kan ini sakit. Ya, padahal sudah jelas-jelas bahwa ada 21 disease yang tidak di-cover oleh BPJS Kesehatan. Ya, sudah jelas di sini. Oke. Ya, next. Nah, slide terakhir, slide yang penuh dengan polemik. Kalau kita lihat slide ini, apa yang menjadi fokus kita? Fokus kita ada di dokter. Bagaimana seorang dokter bisa berani mengimplementasikan, menentukan bahwa case ini adalah occupational disease. Harus berani. Ya. Keuntungannya banyak sebenarnya. Kalau kita di BPJS Kesehatan dibatasi dengan inasi bijis. Ya, inasi bijis. Tapi di BPJS Ketenagakerjaan unlimited pembiayaan kesehatan. Maka ini sangat menyenangkan bagi pasien. Sampai sembuh diberikan pembiayaan. Tidak ada batasan. Karena begitu sembuh nanti akan dinilai return to work. Nah itu. Dr. Rupert sudah turun tangga, waktu saya sudah mau habis. Saya sudah tahu. Oke, ya. Jadi begitu sentralnya, begitu importantnya peran dokter ini. Nah, kita yang kita duduk di kursi yang tulisannya UMM. Ya. Saya bangga dengan UMM. Ya. Saya bisa nonton bioskop di sini. Tadi ininya bagus ya, audionya bagus. Saya berpikir Pak Dekan mungkin mau main apa namanya? Kelamben di sini, ya, kelamben. Bagus. Nah, UMM dengan visinya yang sekarang itu sangat mendukung program ini. Ya. Sangat mendukung. Tinggal bagaimana kita mengimplementasikan, mewujudkan Anda semua menjadi dokter yang unggul. Ya. Ini sangat penting karena jelas di sini perannya jelas. Dengan kita bisa split this is a general disease, occupational disease, kita memberikan rasa nyaman, ya, advantage pada pasien lebih. Tidak ada pembatasan, jelas. Ini aturan, saya ambil dari aturan. Ya, tidak ada pembatasan. Kalau di BPJS Kesehatan masih ada inasi bijis, paket yang diterjemahkan macam-macam oleh teman-teman di pelayanan. Kalau sebenarnya terjemahannya tidak sesimpel itu, rekan-rekan. Ya, maka peluang, nah ini peluang untuk Anda nanti menjadi dokter. Bikinlah pelayanan kesehatan yang berkolaborasi dengan BPJS Ketenagakerjaan atau BP Jam Sostek. Karena nggak pusing dengan pembatasan biaya. Ya, saya kebetulan dokter yang bersama dengan BPJS Ketenagakerjaan. Jadi di kesehatan, wah ini sudah masuk di optional disease, semua ditanggung sampai selesai. Ya, tentu kecuali kosmetik. Ya. Tapi kalau kosmetik misalnya bekas operasi ada keloid, nah udah bersihkan keloidnya, ya. Nah itu. Ibu hamil kecelakaan harus operasi, nah dokter Kusuma ada. Gak ada batasan sampai sembuh, sampai ibunya traumanya hilang, nah, sampai bayinya lahir dengan selamat. Ya, periksa lab, dokter dia ada, gak usah takut, unlimited. Gak perlu harus hari ini periksa 3 3 option, minggu depan 3 option. Kelamaan, kasihan. Ya, oke. Itulah pentingnya kita belajar sistem bagaimana pelayanan kesehatan, pembiayaan kesehatan untuk para pekerja. Why? Karena kita semua adalah pekerja. We all in this room, we are a worker. I'm a lecturer, you a student, Dr. Rubayat is the boss. Ya, direktur rumah sakit, Dr. Putri, nah, bekerja sebagai MC, ya, moderator, sorry. Ya, kita semua is a worker. Oke, next slide. Thank you. Nah, thank you very much. I'm sorry. Mohon maaf apabila ada yang tidak berkenan. Kurang lebihnya, Assalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam warahmatullahi wabarakatuh. Alhamdulillahirabbil alamin. Alhamdulillahirrahmanirrahim, telah selesai sesi materi kita yang pertama dan kedua. Terima kasih banyak kepada Dr. Febri dan juga Dr. Harris yang masih bergabung di Zoom. Kepada seluruh partisipan, sekarang kita menginjak di sesi tanya jawab. Kami persilakan mungkin untuk 2 penanya ya. Jadi setelah ini akan ada sesi berikutnya, tapi tidak menutup kemungkinan jika masih ada pertanyaan untuk Dr. Febri. Nanti di akhir acara masih, Dr. Febri masih standby di sini bersama kami ya dok. Alhamdulillah. Tapi untuk Dr. Harris selesai sampai di sini saja karena di Amerika sudah tengah malam ya dek ya. Ya dipersilakan, apakah ada yang ingin bertanya? 1, 2, ya. Banyak ya, alhamdulillah. Ya adik-adik ini untuk 2 pertanyaan pertama dapat gift ya, seperti yang saya janjikan di awal acara. Giftnya air mineral plus ya dok ya. Thank you for the question, and then please mention your name and affiliation.
Baik, sebelumnya Assalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam warahmatullahi wabarakatuh.
Sebelumnya terima kasih dokter atas kesempatannya. Perkenalkan, nama saya Fania dari Angkatan 2022. Izin bertanya mengenai topik yang dibawakan oleh Dr. Febri, yakni Dynamics of Healthcare Services for Workers under the BPJS Ketenagakerjaan System. Tadi sudah dikatakan bahwa semua penyakit yang berhubungan dengan pekerjaan itu akan tercover dengan BP Jam Sostek. Nah, dengan perkara meningkatnya isu kesehatan mental di kalangan pekerja yang dikarenakan stres akibat kerja, itu menurut dokter apakah cakupan layanan BP Jam Sostek itu sudah memadai dalam aspek kesehatan jiwa? Dan bagaimana seharusnya kita sebagai tenaga medis itu berkontribusi dalam advokasi hal ini? Mungkin sekian pertanyaan saya. Wassalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam warahmatullahi wabarakatuh. Kita tampung dulu dokter. Nggih. Kita tampung dulu nggih. Apakah ada pertanyaan lainnya? Tadi yang pertama sudah untuk Dr. Febri. Ini ada pertanyaan untuk Dr. Harris? Untuk Dr. Harris ya. Yang di tengah dipersilakan. Oh, enggak. Maaf. Ya. Please mention your name and affiliation.
Assalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam warahmatullahi wabarakatuh.
Good evening for Dr. J. Matthew and good morning for fellow participants and my friends. My name is Alia Fania, and if you recognize me, doctor, we've been working together in our paper for ICMEDH 2025 with Dr. Febri also. And before I ask the question, I want to say that your presentation is very interesting and insightful, doctor. And my question is there any programs or plans for the prevention for the working population for outcoming obesity besides using the GLP-1s or giving a lower price without obesity specialist? And that's my question, doctor. Thank you very much.
Thank you very much for your question. Yes. Please, Dr.
Yes,
Harris.
thank you. Oh, I'm sorry. Yes, thank you for that question. Uh, yeah, it's the coverage in the states has been it's been a challenge. Uh, as far as I know, the GLP-1s are what's covered. Other than that, they have, s- and I can't say this is always covered, but when patients leave the hospitals, sometimes what we can do is have a patient referred to a nutrition clinic if we think the patient can benefit from that. Otherwise, we have like physical therapy or occupational therapy, outpatient follow-ups. Rarely we can send our patients to our dedicated obesity clinic. That uh, it's not really covered, unfortunately, by insurance. So that's a barrier. Um, But yeah, I think we're kind of, and it also depends on what's going on with the patient in the hospital. Uh, because that's from an inpatient to an outpatient setting. Now, the outpatient setting I think is a bit easier. Um, I don't have expertise on that area, but I can tell you that the basics of the GLP-1s being covered in a limited amount of states because the cost is kind of it's still kind of high. Um, and so it's a lot of out of pocket unless it's in those 13 designated states where on the map I showed in my on my presentation where they cover for obesity and diabetes, and then the limited 4 or 5 states that covered that did not cover actually for obesity, but covered for diabetes for metabolic syndrome. So I think it's limited, and that's been a challenge for years.
Thank you very much for the answer. Bagaimana? Apakah ada?
Maybe I want to follow up questions for the programs for prevention, doctor. Maybe you have a plan for prevention programs uh, because it could be implemented in Indonesian's hospital prevention programs.
Oh, you mean like
Yeah.
prevention of metabolic
Yes.
syndromes or
Preventions for obesity among workers, doctor.
yeah, that's a tough one because the as far as our data goes, we have some information about our healthcare workers in the US, but it's not robust. It's not a lot of information about our healthcare population, unfortunately, the healthcare workers. Now prevention prevention wise, it's still right now, it's like the patient goes to see their primary care. That's it's kind of limited. And prevention is kind of difficult uh, as as well. It just depends on what's going on with the patient. But prevention is, I think, one of the problems that we've seen in general for helping to improve health in our country in general, not just healthcare workers, but it's just in general.
Okay, thank you, doctor, for your answers.
Thank you very much for the question and answer your time, Dr. Harris. So the first question, uh, excuse me, can you repeat once again in English? Sebelum Dr. Febri menjawabnya. So this question for Dr. Febri.
Yes.
Okay.
So, as mentioned earlier, all work-related illness are covered by BPJS Jamsostek, BB Jamsostek. With the health increasing mental health issues among workers caused by work stress, do you think BP Jamsostek service cover is adequate in terms of mental health? And how could we as medical professional contribute to advocacy on this matter? Okay, thank you, Dokter.
Ya, dipersilakan kepada Dr. Febri, monggo Dokter.
Okay, thank you. No different, mental health, physical health, no different. All of problem we covered the BPJS atau BP Jamsostek. Dasarnya apa? Permenkes 11 tahun 2022. Tidak ada yang lepas dari situ. Semua problem, semua hazard yang menyebabkan terjadinya occupational disease dan itu nyata kemudian stempel occupational disease diberikan kepada pasien, maka itu menjadi kewajiban dari BPJS Ketenagakerjaan atau BP Jamsostek untuk menyelesaikan. Tidak terkecuali mental, gangguan mental, gesekan, singgungan. Selesaikan dan unlimited. Itu enaknya. Ya. Saat ini unlimited. I don't know next. Ya, saat ini unlimited. Jadi harus betul-betul. Tetapi nyambung pertanyaan kedua tadi. Sangat penting namanya prevention. Gitu. Maka dokter yang bekerja di pelayanan kesehatan untuk bekerja harus memberikan pelayanan yang holistik, komprehensif. Salah satunya adalah promotif, preventif. Bagaimana agar orang tidak obesitas? Maka harus dicegah. Cegahnya nggak bisa kita sendirian. Ya, harus dengan manajemen of industry. Collaboration with clinical. Ya. Nah, disinilah kita tahu bahwa begitu sentralnya, begitu strategisnya peran seorang dokter di dalam kesehatan kerja. Sangat sentral, karena dia akan menentukan masuk PHK atau tidak. Begitu kita salah, maka pasien tidak akan dapat pelayanan yang optimal. Itu masalahnya. Ya, nah seperti itu. Ya, jadi pegang rule is clear, but implementation not clear. Gitu. Ya, terima kasih Dr. Putri.
Terima kasih banyak kepada Dr. Febri dan Dr. Harris. Thank you very much. And because of we already reached the limited time, so it's enough for the first session. And please bisa maju ke depan untuk yang bertanya tadi, untuk diberikan souvenir. Minta tolong kepada Dr. Febri untuk memberikan kepada penanya dokter. Terima kasih banyak ya. Sedikit dari panitia. Diintip dulu Dr. Febri. Baik, akhir acara sesi 1 ini sekali lagi saya ingin berterima kasih. Thank you very much for your time Dr. Harris in America in almost mid-time. And we are very happy to see you again in this another opportunity for insightful education for us in Indonesia. And then also Dr. Febri yang selalu kami hubungi untuk acara-acara International Conference di Occupational Health. Terima kasih banyak kepada peserta. Akhir kata mohon maaf bila ada yang kurang berkenan. Wabillahi taufik wal hidayah. Wassalamualaikum warahmatullahi wabarakatuh. Saya kembalikan kepada MC.
Baik, terima kasih. Thank you very much, Dr. Putri Dayawanti, PhD, as the moderator and the speakers too for the very enlightening presentation in this session.
Okay, thank you so much.
But we also thank you for the sponsor who support in this conference for alumni Kedokteran University of Muhammadiyah Malang, Hasta Husada, Java Medica Medical Simulators, and FMM Fajar Mas Murdi. Also thank you for support in this conference today. Okay, ladies and gentlemen, we're on to the second session, and in this session we have two speakers. They are Ms. Gaylin Manalang GR and Mr. Febi Dwi Rahmadi PhD. And the moderator in this session is Dr. Rubayat Indradi MOH. Sebelum kita ikuti bersama di sesi kedua ini, izin saya bacakan terlebih dahulu CV dari Dr. Rubayat Indradi MOH. Dr. Rubayat Indradi MOH was born in Tabanan, Bali, 8 September 1985. Berarti baru saja ulang tahun. Betul, dokter. Selamat ulang tahun, kata mahasiswanya, dok. Okay, the educational background is bachelor degree and medical doctor in University of Jember or Dr. Subandi Regional Hospital, Jember, and then Master of Occupational Health or MOH in College of Public Health, University of the Philippines, Manila. Also professional experience is general practitioner in University of Muhammadiyah Malang Medical Center Clinic, in Bunga Melati Group Clinics, PG Kebonagung Clinics, PG Kerebet Baru Clinics, and Melati Children Hospital. Lecturer in Faculty of Medicine, University of Muhammadiyah Malang, on Department of Industrial Medicine and Department of Public Health. And the other roles is occupational health training, instructor, Faculty of Medicine, University of Muhammadiyah Malang, item bank administration, national committee member for the International Medical Competency exam, and working group member, AIPKE Collaborative Assessment Team. And the CV Dr. Rubayat sudah saya bacakan ya. Dan langsung saja kita akan sambut, please welcome Dr. Rubayat, time is yours.
Thank you, Miss MC. Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh. Good morning, ladies and gentlemen. Today I will be as your moderator on this second session, together with the distinguished speakers from University of the Philippines, Manila, Mrs. Gaylin Manalang Jr., who is joined on site among us, and also from Griffith University, Australia, Mr. Febi Dwi Rahmadi, who is joined online by Zoom. May I greet him, Mr. Febi? Do you hear us?
Halo, Assalamualaikum. Can you hear me?
Waalaikumsalam warahmatullahi
Apa
wabarakatuh.
kabar, Mas Rubayat?
Yeah, good afternoon in Australia, if I'm not mistaken. Is that
Yes,
right?
it is 1 o'clock, 1 p.m.
Yeah, already
our time, yes.
o'clock. Yeah, I'm happy. How are you, Mr. Febi?
I'm very well, thank you so much. Hopefully,
Yeah.
I can see that the international conference ran really well. Thank you. Well done.
Actually, he is also Indonesian. Or you are already changed your citizenship? Maybe changed
No,
to
no.
Indonesian? Not yet?
I still keep my Indonesian passport, so permanent resident. That should be enough.
Okay, thank you. Maybe we will be as a second speaker of this session. So
Yes.
Please wait on the Zoom.
Of course, yeah.
And then for our first speaker, Ma'am Gaylin, her session will talk about ergonomics of sleep and activity time for health and productivity. Yeah, as Dr. Putri before give, I think souvenir. Yeah, I will also give you for the audience beside the souvenir, and then I will give you, I don't know, this is maybe related with your materials, ma'am. This is the voucher for drinking coffee. Yes. So I think almost all of this audience is our students, and you know the students in medical faculty. It's I don't know how about the quality of your sleeping, guys? Are you okay with your sleep? Or such this is a very disruption in sleeping. So today we will learn from actually she was my teacher until now, I think. So I will read the curriculum vitae for Mrs. Gaylin. So Gaylin F. Malang Junior, PTRP MOH. She is now as an assistant professor, Department of Environmental and Occupational Health, College of Public Health, and also member of Physical Wellness Technical Working Group, University Health and Safety Committee, University of the Philippines, Manila. Basically, she is physical therapy, if I'm not mistaken. So this is a very long CV. So I will going to the last part of the CV. Please scroll down the CV. And then now he still working as a field shift. I think maybe you can share the short in short before your presentation. And she will deliver the material about sleep and activity, especially maybe later she will expand about another economic problem. And then the next is Mr. Fabi. His session will talk about from data to action, transforming epidemiological insight into occupational health solution, because he is also expert on epidemiology or epidemiology problem. As we know that as a doctor we cannot abandon the epidemiological problem, especially we are relating with COVID and another problem. So for the first speaker, Ma'am Gaylin, please can you have your podium? Time is yours on 30 minutes. Give us applause to Mrs. Gaylin.
To our esteemed Dean of the Faculty of Medicine, our faculty, students, also of the Faculty of Medicine, my fellow speakers this morning, Dr. Che, all the way there in Baltimore, Dr. Febri, and Doc Feby, who is in Australia. Good morning to you all. It is an honor to be part of this conference, and I'm very happy to be with you, sharing a little bit about the work that I have been doing in occupational health. I am a physical therapist by profession, and for a time I was working with companies in the Philippines implementing ergonomics programs. But I started in that practice actually focusing more on the physical aspect of ergonomics, which really has to do with configuring workstations, making sure that your computer and peripherals are maximized for their ergonomic features. I had the good fortune of joining a project led by researchers at the University of Munich, who are chronobiologists. And because of that project, which came to be known as PhilShift in the Philippines, I moved to a different aspect of ergonomics. Well, let's just say I added a different aspect of ergonomics in my practice. I later on came to study about working time and the circadian rhythm. Okay, so the main PhilShift projects that we implemented in the Philippines had to do with developing tools for determining the biological timing among Filipinos. So there is what we call the chronotype, and it's your biological clock type, and it helps explain the phenotype of your daily experience, so what time you are awake and what time you are asleep. So in this session, I sought to compromise with the initial topic about ergonomics and bridge with sleep and activity time to present it as an ergonomics concern. Okay, so earlier there was, I detect some enthusiasm when you were asked about how well you slept, and also your enthusiasm for the coffee voucher. Okay, so I'm intrigued. Okay, so we're going to touch more about that in this session. Next slide, please. Okay, so we will be going through an organization of daily activity and sleep window. As we know from literature, that is mostly about Western populations, and slowly adding to that information about Asian
Recording in
populations.
progress.
There's also some part of our discussion that will be about circadian rhythms, particularly one, which is that of the sleep and activity cycle. And we will use that as a sort of jumping point or jump-off point for putting up the idea that the working time that we observe is highly influenced by how well we are sleeping. So the window of sleep influences how we perform during the window of wakefulness. And my argument is that when there is some decrement or deficit in sleep, very much so your activities when you are awake are affected. So when we say working time, we should not just be concerned about what time we start at work or what time we end at work. We should be concerned also about what time we go to sleep, how long we sleep, and what time we wake up. Okay. We also would like to dwell a little bit on what we consider to be good quality sleep, because that is another factor which contributes to a lot of conditions that workers and even those in the general population actually experience without them realizing it. In our first lecture, one of the populations that Dr. Che mentioned had to do with shift workers. And we don't realize it, but even if we are not a shift worker, depending on our sleep behavior, we might actually be doing a shift work-like routine without realizing it. And if that is the case and you identify to that without you realizing it, that you are some sort of a shift worker, be assured that there are ways to manage the experience. Sometimes we cannot help it because there are schedules that are imposed on us, or maybe there are important things that we have to manage or attend to that affect our sleep time. But there are ways where we can offset any negative or adverse effects of such experiences. Next slide, please. Okay. So here, let me ask first the question. Which do you identify with as to how you felt when you woke up this morning? Are you more of photo A, well, looking like they're well rested, slept their fill during the evening, or are you more of letter B, that you knew you had time to come here, or you had to come here by a certain time, but you felt you still had to sleep in? Who is more of photo A, that when you woke up this morning, you were ready to take on the day? So only a few hands. I'm sad that most of you are photo B. But that is a common experience in many populations. Next slide. You would have been photo A if you said that you slept through the night, that you woke up refreshed, your sleep was very deep, and you could say that you slept long or long enough. Otherwise, you're photo B. One thing very important is also another expression of good sleep, which is, next slide, that you slept at the right time. Okay, so the question is, what is the right timing for sleep, which will later on influence the right timing for work and the right way of working? Next slide. Okay, so sleep is very important. Okay, and we know more about sleep nowadays than 5 decades ago, when there was not much instruments and methods to study how sleep happens. Okay? And it has value in maintaining our immunologic function, for conserving energy so that we could function throughout the day with the amount of energy available from our food.
It's important, especially in those who are not yet of mature bodies with their physical development. And for those of us who maintain a routine at school as students, or a routine at work as different types of workers, good sleep helps our mood throughout the day. It helps maintain ideal psychological states. It helps in disease prevention, such as the metabolic conditions that were referred in the first session. And it's very much important also in overall well-being. Okay? Next slide. Okay, so we have this notion that sleep is just one episode. But more also nowadays, we see sleep to be biphasic. There's naturally a long period of sleep at the end of the day for us, and then there is a shorter period of sleep which naturally occurs right about after midday. Okay? So the thing is, that period of sleep after midday would sometimes be obliterated because we have to keep a routine where we have to be awake. Okay? So it's not just that we have one long sleep at the end of the day. For most individuals, if we don't have a routine, naturally you will feel sleepy after midday. And it's just a very short sleep period. Next slide. Okay. So how do we see sleep to be? And how do we explain why sleep happens? Because it happens naturally. Let's have a next slide. Okay. So when we say circadian rhythms, we're referring to cycles of 24 hours phenomenon in our body. I think my slide is sleeping. Okay. So these circadian rhythms have a cycle of 24 hours. They're predictable. They happen daily in our bodies. We may have very obvious manifestations of it, like the sleep and wake cycle, but sometimes most of those cycles we don't actually notice. Okay, so what we know about sleep is that we don't just have one clock in the body. We have a collection of clocks in the body. There are cell clocks, there are tissue clocks, and then there are organ clocks. And overall, there is what we call the biological clock. So that collection of clocks influences the 24-hour rhythms that you experience, including the activity and sleep rhythms. Okay? Now, there are endogenous and exogenous factors that could influence the circadian rhythm. Okay? The most, shall we say, the factor that we react the most to, which sensitizes the circadian clock, is the experience of natural light. Okay? Nowadays, in indoor environments, we experience artificial lighting. Okay? Artificial lighting in indoor environments seem to be the norm for most people. But actually, the 24-hour rhythm that naturally occurs in our body is more influenced by exposure to outdoor lighting. Okay? So even if we have this bright lighting, this compared to natural light, your body will respond more to exposure to natural light. Now let me ask you, how many minutes did you have of sunlight this morning? Oh, 0. Okay, because you just go straight to the room, right? Okay. So that experience also influences those windows for napping and sleeping at the end of the day. Next slide. Okay, so I pretty much discussed the next slide. Next slide, please. And the next slide as well. Okay, so the sleeper activity cycle is the output of our circadian rhythm working. Okay, and the oscillator that causes that sleep cycle is the chronotype of the individual, which is because of that collection of clocks. Next slide. That collection of clocks will be influenced by largely human behavior and exogenous stimuli, especially lighting. It can also be influenced by the routine that you keep, what we call social clocks. And for students, that's the school hours. For workers, it's their working hours. Next slide. Okay. So this model explains why sleep happens. When this was developed in the late 70s, early 80s, they explained verbally explained sleep this way. Sleep has two processes influencing it. Okay? There is process S, which is basically sleep homeostasis. It dictates the need for you to sleep. Okay? Then it interacts with process C, or the circadian component. Basically, the circadian component in this theory is the one that influences how much you need to be awake. So when process S is at its height, you have the highest sleep pressure, and when process C is at its lowest, that's when you least need to be awake. When they coincide, that's when you start feeling sleepy and go to sleep. Okay? With more recent developments in investigation of sleep, they found that that period of coinciding happens after midday, slightly. There is a slight dip, so that this theory is enhanced, that it says now, that we know now, that you have that window of napping because of that phenomenon. Next slide. Okay. So this is what a diurnal individual experiences. Over the course of a 24-hour day, the succession of the physiologic events that we experience will be the same for all of us. The difference lies in what time those events happen within the day. Okay? For this illustration, which was published in the 2000s, it's largely from data of Western populations. And the wisdom that they had at that time was that the mid-sleep time, which is the deepest sleep, okay, which is used as a hallmark for the chronotype, measurement of the chronotype, for Western populations, mid-sleep is at 2 a.m. Okay. Now, we do have data from other populations and some from Asian populations that say that the mid-sleep for Asian populations is different. The thing is, the construct that we follow, the social constructs that we follow, are highly westernized schedules. And the impact of that is we are following routines that are largely fit for the routines of Western populations, but we have an Asian body clock. Next slide. Okay, there is also the fact that a behavior that we pursue can influence the clock. So late at night, instead of following your natural propensity to start sleeping, you may be engaging in behaviors without you knowing it that delay the start of sleep. For sure, you would have heard of melatonin, the hormone that is associated with induction of sleep. Melatonin starts being expressed in the brain 2 hours before you actually close your eyes. And if you're exposed to artificial light, especially the blue light from your devices, the expression of melatonin is delayed. Okay? And that is among the factors that causes you to sleep later than you should. Next slide. If you live far from where you live, where you work or where you study, there's another factor that curtails your sleep that happens in the morning. And that's you waking up using an alarm clock because you know you have to commute a certain distance over a certain time to get to your appointment. Okay, so you can cut short your sleep 2 ways without you realizing it. When you use gadgets at night or are exposed to artificial light at night, and in the morning when you wake up early because you have to catch up for a certain schedule. Now, remember what I said earlier about natural light being the strongest stimulus to affect our body clock? Okay, what you see here are sun graphs. So on the x-axis are months of the year, and the y are times of the day. So throughout the year, what you see here is the different day lengths. In the bottom, we have for London, next to that, St. Petersburg in Russia, then Manila, and then on the very top is Malang. Okay, so this visually gives you an idea of how long the day is and how long outdoor lighting is bright. For Manila and Malang, the Philippines and Indonesia, we basically have more or less a consistent day length throughout the year. But in other countries, there are shorter day lengths and then longer day lengths depending on the seasons. And this is one factor that is said to explain, or has been found to explain rather, why sleep behavior is different from population to population, and it's even related to mental health conditions as well. Next slide. Okay. So we define good sleep, good quality sleep that we want so that we are in tip-top shape during working time when we are awake by saying that we perceive we have had good sleep, when we feel that we have been restored by sleep, and we've had uninterrupted opportunities for sleep. We can also say that we've had good sleep because we slept our fill. We had long enough sleep. Okay. Next slide. Now, we have to also be aware that the idea that we have to sleep 8 hours is based on Western data. And it's not true for everybody. Okay. So this is just a visual representation of when sleep happens for us. There are other ways, and we can use it also to show how others could define their sleep duration. Next slide. Okay. So what we know about Filipinos is that the lighter bar represents data from German population, and the darker bar is, or a darker line rather, is of Philippine population. So this was from a small analysis of the PhilShift data that we collected about chronotypes in Filipinos and data from my collaborator in Germany. And from here, we found out that Filipinos on average would have a sleep duration of almost 7 hours. But there's a big difference between the sleep duration on work days, which is short compared to that of the free days. If the sleep duration on work days is not the same as that on free days, that's an indication of what we call social jet lag. You would be familiar with travel jet lag, but social jet lag encompasses that and you actually having shorter sleep on different times of, at different times of the week. Okay, so it may be because of pursuits, maybe like school or work. For shift workers, it's very obvious. Their sleep is curtailed by them doing the late night routines. Okay. And what we see here also is that on work days, the sleep duration of Filipinos is shorter compared to the Germans, but on weekends, more or less, the average would be the same. So what does that mean for us in the Philippines? Maybe we have more jet lag, social jet lag in the population compared to German population. I wonder now if that is the same for the Indonesian population. Next slide. Okay. So we can say that you are a long sleeper if relative to the average in the population, you'll sleep longer. And the opposite when you're a short sleeper. Okay, so when we say you're long or short sleeper, it has to be referenced against the average in the population and not the average that we know of that literature tells us, which we now know is largely of Western population. So if for Filipinos, the average for us is 7 hours, long sleepers for us would be those sleeping more than 7 hours, and short sleepers will be less than that. Okay? But for Indonesian population, I found one, I did not find the original article, but it mentioned that on average, from their respondents, majority from Java, the average sleep duration is 4 to 6 hours. So for us Filipinos, we sleep slightly longer than you. And long sleepers for you might be average for us. Is that interesting? Next slide. Okay, so we have differences in go to sleep and wake up times between individuals and go to sleep and wake up times across one's life. The chronotype is not like your blood type that is constant throughout your life, unless you undergo a medical procedure. Okay, so the chronotype is something that changes over the course of your life. The tendency is that when you're very young, you have an early chronotype. Your mid-sleep time is earlier in the night. But as you grow older and peaking at age 20 or 21, your mid-sleep time becomes much later. And in literature, they even say that this late chronotype is a hallmark for the end of adolescence. Because after 20 and 21, your mid-sleep time on the average goes earlier again. Okay? So keep that in mind. Throughout your life, your sleep timing might be different. You will not expect that how you slept when you were in school would be the same as when you were working. This could help explain why us who are working sometimes get frustrated. We remember in university, we can pull all-nighters. But when we're already working, when it's important to pull all-nighters from time to time, we can't do it anymore. So there's a basis for that. It might be rooted in your chronotype changing. Next slide, please. So the third way that we can say that we have good sleep and that we can pursue work well would be that we slept at the right time. Okay, next slide. And we know now that there's interaction between actually 3 types of clocks every day. Your internal clock or your chronotype, then you have the external clock that is your social clock, which could be your school time or your work time. And then there's the second external clock, which is the geophysical time or the environmental clock of 24 hours. So the synchrony of those 3 would spell success for someone who is doing work at a certain time of day. If you're a shift worker, the idea that your internal clock will be synchronized to your social clock, where you have shift working or night work, is something that companies would like to prosper. But in theory, no one can reverse their body clock. Okay, many reasons for that. First, it's genetic. Second, there are a lot of endogenous factors that you have to contend with. And third, we have the weekend. The tendency is that your routine during the weekday will be different during the weekend. And that if you are doing shift working during the weekday, any adjustment of your circadian clock to favor a late night routine might be reversed when you pursue the day routine during the weekend. Next slide. So what we promote for not only persistence during extreme work routines like shift working, but also for those to be able to maintain their state of health when they're not doing shift working is the pursuit of sleep hygiene measures. Okay? So with sleep hygiene measures, we recognize that the solar clock is constant. You cannot change it. Your experience of light is due to the environment. But you can modify how you pursue your social clock, and you can also protect your rest hours. Okay? So next slide. What I'm wearing in that photo are instruments for measuring the circadian clock. In the projects that we pursued, we were using questionnaires that we validated. So these are German-developed questionnaires that we validated in the Philippines. And what I was trying out there are 3 models of what we call actimeters. These devices are passive monitoring. They can measure your activity like an accelerometer. They might have features also to gather your total light exposure throughout the day for a certain number of days. And we use these in chronobiology studies to understand how an individual is pursuing how an individual's chronotype manifests as a phenotype. Okay? So if there is a lack of synchrony between the person's chronotype and the social clock of the person, then that's when you need to promote supportive behaviors, which largely goes by the principle of them protecting their rest time and so that they could do their best during their working time. Next slide, please. Okay, so we mentioned about early sleepers and late sleepers, long sleepers and short sleepers earlier. There's also the concept of the early sleepers and late sleepers. And again, in a population, there's an average sleep start time. And relative to that average, you could either be a typical type or a late sleeper or an early sleeper. Next slide. Okay. If you are of the natural predisposition of being asleep during the day and awake at night, that's also a chronotype. Okay? So there are early sleepers, late sleepers. We can say there are nocturnal and diurnal individuals too. Next slide. Okay, so any nocturnals here? If you are here, I expect you to be asleep already. Okay? Next slide. So there are true nocturnals in people. But there are, of course, animal species that are majority in their population, they are naturally nocturnal. Okay? But for most in the population, for humans, majority are diurnal individuals. And this is the reason why we need shift work management programs. We cannot say that, for example, in the night shift in the hospital, okay, look for the nocturnal people, and they will be the ones doing the night shift. That would be ideal. But if your nocturnal people are less than 10% of the population, you cannot staff your hospitals or many industries. So us diurnals have to be helped along when we are doing late night routines at work. Next slide. Okay. So this one shows the average chronotype of Filipinos, what the average mid-sleep time is in the population. So from our study, we know that for Filipinos, the mid-sleep time is 4:30 in the morning. And for German population, this is 3 a.m. So difference in the populations, again, of how sleep timing happens. So 25 years ago, the wisdom was that mid-sleep time is at 2 a.m. But now we know better. Okay, so there are differences between populations. This I did not find data about among Indonesians. There are studies that use the same tools as we did, but it was about specific populations like individuals with mental health conditions or certain groups of students. I've not encountered population data in the general population. Next slide. Okay, so have a look at, remember where the star is. What I'm showing you are visualizations of how the typical week for a diurnal chronotype looks. This is typical. This would not be problematic if you have slight differences in the sleeps or start or end time. But, next slide, if your sleep looks like this, that you feel that your sleep advances throughout the course of the week, so that at a certain time of the month, your sleep hours are really odd, then this could be indicative of a problematic sleep type. Next slide. This is what we call the progressive delay in sleep. And then unfortunately, there are those who have this, next slide, they have very much fragmented sleep. Okay, so next slide. So this fragmented or broken sleep can also be seen in the population, but it's very rare. So the two indications or the two visualizations that I showed, those are indications of people who really need to see someone for medical management. It may be that they have genetic conditions that explain their sleep phenotype, and they need to understand what is going on. Okay, next slide. So, anyone here on B and C? If you care to volunteer, I hope not. But be assured that if you are, there are ways to help you. Okay? And for most of us, Saturday morning is a special thing. Next slide. It's an indication of the social jet lag. If you experience it in Saturday morning, you sleep longer in the morning. Okay? It's like you're trying to catch up on sleep. So it means your sleep timing during the workday is different during the weekend when you don't have any routine. You sleep longer. Okay, so it's not just fatigue. It might be your chronotype really, manifesting itself. Okay? So next slide. Wait, don't go back to that anymore, but I just wanted to say that the timing can be influenced again by use of artificial lighting and also behaviors such as commuting. And if we regularly experience that or pursue those behaviors, it's more likely that we have social jet lag. And the lack of synchrony between your work time and your chronotype, or your social clock and your body clock, means that you are not correctly or sufficiently entrained. Okay? And the entrainment is the state when you have your clocks aligned, the social clock, the solar clock, and the body clock. Okay? If you're a shift worker, obviously, your social clock and your chronotype are not aligned, and that's when you have social jet lag. And it can lead to many consequences that are basically non-communicable diseases and some mental health conditions. Next slide. Okay. So this is just a reminder for me to say that we may be thinking of the brain and the pacemaker in the brain, which is in the suprachiasmatic nucleus, as causing sleep. But actually, the sleep cascade happens because many other physiologic events happen. Okay? So the peak times of manifestation of certain physiological factors and physiological functions in the body, they don't happen at random. They happen at a certain time of day. And them being able to happen consistently at a certain time of day will also influence the timing of your sleep. Okay? Next slide. Okay. So just bringing this back again to drive home the point that we expect for everyone to have the same succession of physiologic events, but the timing may be different from person to person and between populations. And if you are doing work routines that are extreme, like shift working, the thing is, you cannot reverse this so that it will follow your routine. Okay? So what you really need is supportive behavior out of the working time to preserve your sleep. Next slide. So we manage the factors that can change the quality, quantity, and timing of our sleep. Next slide. Through sleep hygiene measures. Okay? And in the interest of time, next slide, I will just breeze through the tips, and you can ask me questions during the Q&A later. First, you encourage the natural sleep duration and timing. Second, you strategically avoid coffee and other stimulants. Last night, when we were at dinner, I realized going to the restaurant that even at night, everyone is out drinking coffee like water. Okay, so now the wisdom that we have currently is that the half-life of coffee in the body is 5 to 7 hours. And we say that we advise that we don't drink coffee in the afternoon or early evening because it will put back your sleep. And I'd like to present now to science the wonderful people of Malang who drink coffee well into the night and still sleep well. Okay, so many of the advice, again, I'll put that to a small mark there and tell you that it might not necessarily apply to all populations. Okay. Maybe you have your own time givers. Maybe coffee is not really the same effect as other populations on you. But just be aware, what literature tells us is that with the half-life of coffee, you shouldn't be drinking in the evening, okay, and afternoon as well. Then take lighter meals at the end of the day because supposedly the upset of the gastrointestinal system can also affect your sleep, especially if you're eating very heavy meals, and more so if you're a shift worker who at the end of the shift in the morning pretend that the breakfast is a dinner. It keeps you from sleeping right away. Then protect the routine that provides the window of opportunity for sleep. So this one, I think we cannot compromise. 2 hours before you start feeling sleepy, minimize your gadget time. Because that is something that is quite consistent in literature. If you cannot help it, make sure you put up the blue light filter in your gadgets. That part of the spectrum of light is the one that the brain reacts to the most and affects the start of the sleep time. Then, minimize light exposure before going to sleep. And lastly, modify the environment to allow for full uninterrupted sleep. If you sleep with family or you are in a dormitory, if someone needs to sleep, respect their sleeping time so that you can ask them to also respect your sleeping time. Okay, thank you very much, everyone. I had slides that I did not present, but I told you enough so you can ask me questions during a Q&A. Thank you.
Thank you very much, Ma'am Lily. I think it's very interesting. But my first question is, how about this voucher, Ma'am? Should I avoid to share with the audience? I will use it myself. Just give it to you. Okay, thank you. Okay, please have a seat, Ma'am, and then we go to the next speaker, Mr. Fepi. Are you there in Zoom? Hello, Mr. Febi.
Yes, I'm here.
Yeah, can you hear my voice? And then I will read your CV first. Can the committee please share the CV? I will read your CV first, and then after this, you will have 30 time for presentation, and then we have Q&A session, and then with Ma'am Gaylin. Can you share the screen? Okay, I will read the curriculum vitae. Name, Dr. Febi Dwi Rahmadi. Place, date of birth, Cirebon, 20 February 1981. And then now he is as a permanent resident in Australia at Griffith University, Gold Coast Campus, Queensland, I think. And then for educational background, scroll down, please. For the formal education, 2016, he pursued the PhD, School of Environment, Griffith University, Australia. And then 2009, Master of Science in Public Health, Griffith University. And then 2004, Bachelor of Public Health Epidemiology, University of Indonesia. And so many employment history. I will not read one by one, and then going down, please. And then so many organizational experience. He is also Muhammadiyah Special Branch for Queensland. Maybe we can give applause for him, because we are also in one big organization. As I mentioned to Ma'am Gaylin, that we are one of the big Islamic organization in Indonesia. I don't think, maybe in the world also, maybe number 2 or number 3, the biggest society organization about Islam. And then also so many academic experiences or skills, role as a co-leader and co-researcher, and then so many roles. And then going down, please. Also publication, so many publication, and for the time, maybe we should start your time to present about something about epidemiology. I don't know, because my subject in epidemiology, Ma'am, if I was pursue Master of Occupational Health, this is very challenging for me. It's very difficult for me, I think. But now we are learning in 30 minutes. So please, we can give applause again for Mr. Febi to present his materials. Time is yours, Mr. Febi.
Thank you so much, Mas Rubayat. Please allow me to share my screen. Yeah. Can you see my screen? Can I please confirm that you can see my screen?
Yes, clearly.
Okay, well done. Okay, first of all, Assalamualaikum warahmatullahi wabarakatuh. It is a pleasure for me to be here in this conference. Madam Gaylin, Professor Gaylin, it was so great to meet you through Zoom, and I learned a lot from you as well. And it's actually happened to me as well when you were saying drinking coffee like drinking water. So that is actually my case as well. The only time I did not sleep is when I was drinking coffee, but straight away after I finish my coffee, I can fall asleep. So maybe I need to I need to do a lot of things to basically to reduce my coffee consumptions. But thank you so much. I learned a lot from you. Thank you so much for inviting me, Mas Rubayat, Dr. Febri, previous speakers, and maybe Dr. Mehdi is there as well. So it's a pleasure for me to be here in this conference. As public health researcher and practitioner, I always believe that data is more than just number, right? So many of us maybe think that data is just number, but it is actually more than just number. So it reflections of lives, of communities, and of the environments in which we live or work. So in our presentation today, we will be talking about from data to action, transforming epidemiological insight into occupational health solutions. I'm not going to take you to the boring epidemiology lecture, Mas Rubayat, because yes, I have to admit that epidemiology lecture is a bit too boring, too many numbers. But in today's presentation, I'll be looking at more in terms of how we can translate evidence or research evidence into something that can make some changes at the community level. So I divided my presentation into 3 parts. So the first part will be understanding the roles of epidemiological science. We'll be also talking a little bit more about the basic of epidemiology, study design. I'm not going to explain in detail in terms of study design, otherwise 30 minutes is not enough. And also looking at what are the roles of epidemiologists in the context of occupational health and safety. And then the second part will be about the translating data into actions, looking at some models, looking at some examples. I think Professor Galen also just mentioned some numbers as well previously in her presentations. I think those are actually the role of epidemiological data and provide some insights for policymakers. And then lastly, I'll be talking about some examples from Australia. I'll be showing you the workplace. I'll be showing you the examples of how data is involved in the context of policymaking process, in the context of occupational health and safety, in the context of Australia. First, some basic principles. We need to understand that health is a human right, although in reality of life, we sadly we have to say that to some people maybe health is a privilege. To some people, health is not a human rights, right? So hopefully in the context of Indonesia, health is human rights. So healthcare is also human rights. So equal access for all human beings in Indonesia. Hopefully that is the case. It is very important for us to then understand that in the context of workplace, that for all workplace and also workers, they should be able to attain the highest attainable standard of health. Okay, because that is the fundamental rights of every human being. When we say human rights, then it's actually entitled that for all human beings, just because they are that person is a human. So it does not matter in terms of what type of work, does not matter what type of religion, what ethnicity, and etc. Right? In reality of life, when people work in factory A and then factory B, we can see that factory B is better than factory A in terms of the healthcare, in terms of the environment, right? So maybe factory A has more hazards in their factory. So this is not right. So as a medical professional or public health professionals or policymakers, we need to really step up and really make some changes if it is happening. And I'm not going to use this in detail, but just to remind all of us about the preamble of the Constitution of the World Health Organizations, which is actually showing to all of us that health is a human right for all of us. And therefore, in May 2010, so WHO launched the Health Promoting Workplace, which is actually a model. You can actually Google it, and then you can download the model, the guidelines provided by WHO in terms of health promoting workplace. So, of course, when you talk about occupational health and safety and health promoting workplace, so there's is actually quite similar, but not the same, I would say. But it is actually beyond than just talking about occupational health and safety. So it's more about how we can make sure that when people work in our workplace or in our factory, in our university, when they go back home, they become healthier and healthier. So you can imagine, right? So when we come back from our workplace, when you arrive at home, we feel we are healthier and healthier. So it's not just like exhausted and thinking about the work tasks that has not been completed and etc. So this is something that we've been actually struggling a lot in terms of what model we can actually create. So then when people work, when they come back home, they become healthier and they become better in terms of their well-being as well. I'm not going to read this in detail, but this is just to remind all of us about the framework for determinant of health, because here we can see the upstream, downstream, upstream, midstream, and downstream. So the downstream have the most direct impact on health and well-being, but these downstream factors are influenced by midstream factors, which are in turn influenced by the upstream factors. So it's like if you're climbing a mountain, you have the upstream, midstream, and then downstream. Whatever people are doing at the upstream, that will impact the midstream, and then at the end of the day, that will also impact the downstream factors as well. So if you look at this in this screen, that we have safety factors, we have psychosocial factors, we have health behaviors, right? We also have the environmental factors, which is probably related to our workplace as well. And there are a lot of things like here, including as well the socioeconomic characteristics and etc. So different type of jobs. That's why we have blue collars, white collars. So that will then also contributing the what kind of hazard do they actually exist in that type of environment, right? So yeah, so this is something that we need to really understand as well in terms of the model. So because this is also important when we would like to intervene, when we would like to then make some interventions, actions on how we can potentially, make some changes. So given that health is a human right, and then we understand the social determinant of health, we have upstream, midstream, downstreams. So what are epidemiologists doing, right? So here you can see that this is a picture of detective. So when I was doing my bachelor degree back then, long time ago, when I was doing my epidemiology major, and the lecturer said that you will be a detective. Okay, so this is actually quite right, because what we are actually doing is we collect and analyze data on disease and health trends to identify their causes, identify how they become spreading across the community, and develop preventive strategies and policies to protect populations. So it's like a detective process in epidemiology. So if you look at this one here, so we gather clues or data collections, right? So we would like to see the public health reports, community surveys, or maybe laboratory analysis, and we probably would like to identify who is affected. Okay, so the person, the age, the gender, the occupations, type of occupations, department, right? So we also would like to also understand where is it happening, the place, geographic location, settings, and etc. So this is also important information that we would like to know as well. When did it start? So the time, date of onset. We can also potentially understand the duration of symptoms as well. And next, we also need to also understand the interrogating the suspect. This is where we do the data analysis, right? So we use statistical tools and model to analyze the gathered data. So after this, you will be seeing a different type of study design, which I have mentioned earlier. I'm not going to explain that in detail because we don't have time. Looking at our pattern, because we need to look at the pattern, because nothing happened just like that. So there will be a pattern that we can learn. Okay. So, and then what we can do next is connecting the dots. So this is where we do the interpretations of data or interpretation of findings, trying to understand, try to reveal how a disease spreads or why accident happened in the context of factory, for instance, or maybe occupational disease, why it is happening. So why those population exposed to this potential or this illness, why the other did not. So this is something that we need to really understand. And then hopefully we can also come up with a solution. Okay, solving the crime. We call it solving the crime or public health interventions. So this is where we conduct preventions, control, and then how we can actually treat the illness as well. So this is where we need to work in collaboration with a lot of health professionals. And then last but not least, we need to communicate the solution. So we need to do some reporting. So this is basically what we are doing in the context of occupational health and safety or health workforce, in the context of factory or industry. And the next slide is more about the themes of the roles of epidemiology science in occupational health, because I forgot to actually mention this. So epidemiology, for those who probably don't know, which I believe you all know, that epidemiology is a study how disease and injury work or occur in a populations, right? In the context of occupational health and safety, so that population is the workforce. So that population is the workers. Okay, so the epidemiology science in occupational health. So what we are doing is to identify the pattern, the causes, the effects of work-related issues, and also potentially enabling evidence-based interventions. So these are the 8 different themes that we are doing. So identify the hazards, measure disease burden. So this is where we need to understand the prevalence, the incidence, the fatality rate, and potentially we can also understand the attack rate as well, and etc. So a lot of things that we can actually measure. Investigate outbreaks, clusters. So this is also important as well. Exposure response assessment, risk assessment and preventions, evaluate interventions, inform policy and regulations, support worker health equity. So this is something that we are actually doing. So in terms of occupational health and safety intervention domain, so there are 7 Ps. Correct me if I'm wrong. Programs, practices, principles, procedures, products, pills. Pills in this context will be medicines that need to be consumed by the workers. And then last but not least, the policy. Okay, so there are quite a number of intervention that we can actually conduct, but this has to be based on the evidence that is collected through research previously. Just would like to give you an example of the program, like behavioral program, for instance. We have training programs, safety training for workers in high-risk industries, constructions, or in healthcare to reduce injuries and improve hazard awareness. Or stress reduction initiatives, it is also very important, so which is related to behavioral aspect as well. In terms of product, we have engineering and technological, like noise reduction technologies, ergonomic equipment, policy intervention. We have smoke-free workplace policies. So, we have FCTC, Framework Convention on Tobacco Control. So that is also so much related to create a safer environment for workforce as well. Seasonal influenza vaccination program. So this is also related to the occupational health and safety as well, which is provided from the information from the research or study beforehand. I just would like to give you one one more examples in terms of the, this is one of the great examples of asbestos. So asbestos previously, it is widely used by all countries, including here in Australia. So from early 19th centuries to 1970s, that's why a lot of houses that was built back in 1960s, 1970s, a lot of houses there still, they use asbestos. So when that house in Australian context, I'm talking, so when that house need to be, need to be maybe reconstruct or maybe need to be repaired. So there are certain regulations need to be done because that house contains asbestos. Okay, and this is also looking at from the research and also epidemiology data as well. Okay, when you look at this figure here from regulatory milestone. So in 1924, asbestos was linked to lung damage. So it has been proven by research that asbestos can lead to cancer. Okay, especially the asbestos exposure to mesothelioma. Okay, so this has been discovered since then. This, however, if you look at regulatory milestone, so you can see from 1924 until 1985, 1970, 1976, 2024. Okay, so there are a lot of gaps. You can see there is a gaps between the research and then the regulations is launched. Okay, so what happened, in terms of the gap? You can see that, this is just one example, which is asbestos. So a lot of other things as well. At the moment, what is happening in Australia, for instance, they are looking at the 5G. We all have 5G. Okay, I'm not sure. I think in Indonesia, you also have 5G now. 5G has the potential effect on children's brain development. So the 5G, internet, because now become from 4G, 4.5G, now become 5G. Okay, maybe in the future, they will declare that 5G is not good for our health. Okay, so that is also based on research. At the moment, we have research cancer center in Brisbane, in Gold Coast, at Griffith University. So now they're working on that 5G impact on cancer, especially thyroid cancer, using mobile phone. So mobile phone and thyroid cancer. So anyway, so that's another topic, right? So there's also occupational, that is also related to occupational health as well. So if you look at here, of course, then collecting evidence is the key. So we need to collect evidence. Remember, we are detectives, so we need to collect evidence. So collecting evidence is the key. So there are a number of methods that we can actually do, depending on the settings, depending on what data is available, depending on the research questions as well, right? Whether we have group as a control group, whether there is no control group. So there are a lot of things. So you can see this is actually, I took this from this reference. So all reference is provided at the bottom of the page there. So you can actually have a look at this as well. But these are the basic epidemiology study design that we can actually use. But mostly is case control, cross-sectional, cohort, depending on what data is available. But then the problem is now how we can then translate from data into something that can be actionable. Okay, so from data, so this is what we call by the IKW pyramid. So from data become information, from information become knowledge, from knowledge become wisdom. If you still remember the asbestos case that I just mentioned earlier, so from 1924 until 1970, so it took about 30 years gap until that become a policy or regulations. Okay, so that is actually quite long. So you can imagine like how many people have been exposed to this hazardous materials because the regulation was not there, right? So therefore, it is very important for us to then understand how we can then transform evidence into actions. I don't have much time. Actually, I only have about 8 minutes to go. So I would like to show you this. This is a very interesting picture, and this is not my own picture. I took this from internet, but this is in Queensland, okay, in Australia. So there is an air balloon conversation. I took this from Jonathan Lomas, and Jonathan Lomas is from Canada Health Department. So it's from the person at the balloon, an air balloon asked the person on the ground. And then he said, so where am I? The people in the balloon asks. You are 30 meters above the ground in a balloon, was the reply from below. And then the person on the balloon said that you must be a researcher. And then the person on the ground said, yes, how did you know? Because you told me what you told me is absolutely correct, but completely useless. And then from the ground, they said, you must be a policymakers. Oh, yes, of course. How did you know? And then the people from the ground said, because you don't know where you are, you don't know where you're going, and then now you're blaming me, researching. So this is actually something that is potentially happening with us, you know, in our daily life, you know, between researcher and policymakers. That's why there is what we call by potential leaking pipe from the evidence to practice. So that's why I put this a sad face. So this is actually a case study. This was in the United States, looking at from the priority for research funding. So looking at from the funding of a research until the research produce evidence, until that evidence become a practice. So it takes at least 17 years. Do we have 70 years, you know, to basically apply something in our workplace? Of course not, right? So it's a lot of time. 17 years is a lot of time. But this is not from me. This is from what they say. Okay, so you can have a look at this reference as well. From the research funding, from the peer review of grants, from publications, from research synthesis, from guidelines for evidence-based practice, until the dissemination and informations. So a lot of things will happen between that period of time. So there is something what we call by implementation science. Okay, in the context of research, we have translational research. So it's more about how we can shorten the pipeline. So how we can make sure there is no leaking in the pipeline. So if you remember the one that I just showed you earlier. So shorten the research to practice pipeline. This is really important, right? So asking this, you know, like, does this intervention work under optimal conditions? Does this intervention work under real world conditions? When, how, with whom, under what circumstances, and why does this intervention work? So when we conduct epidemiological study or research, we need to also have something like this as well as part of our questions. Okay, so I'll give you also another a model. So this is what we call by we have scientific discovery, the efficacy, the effectiveness, recommendation to practice, and practice to public health. So then we can have a look at this model to see, you know, when we conduct research, epidemiological study has produced some data, how that data will be important, you know, to, if you look at this is from the Institute for Safety, Compensation, and Recovery Research, how that data will contribute to three main things. So if you look at this one here, I'm not going to read this in detail. So research, dissemination, and diffusion. So this is important, the first one. Informing decision-making, contributing to societal change. So these are three things that is important when we conduct research. So it is very important to make sure that the data that we produce is usable, useful, and used. So triple U. So usable, useful, and used by the policymakers. The next one, so I'm not going to read this in detail as well, but if you look at this, you can also have a look at this reference as well to see how research has impact. You know, we have research capacity, immediate outcomes, intermediate outcomes, and then the final outcomes. So research that conducted, especially in the context of occupational health and safety, is so we need to have this in our outcomes of research. Okay, this is important because otherwise, the pipeline from research to policy making process, that will be too long, and maybe there is a leaking as well in between. Just a couple more slides before I just provide you with some example from Australia. So health promoting workplace planning. So this is basically the idea, in terms of, if we have unhealthy, this is the like a business concept, right? So we have unhealthy and unsafe environment, and then we have work-related stress that will lead to unhealthy personal health practice. Okay, that will lead to some certain diseases, chronic and non-communicable disease. And work-related stress will lead to accidents related to job dissatisfactions. And this will lead to absenteeisms. This will lead to workers' compensation claims. And then if you look at down there, we have that will increase costs, that will decrease productivity, that will provide some consequences like fines or maybe imprisonment, and then business failure. So therefore, this is since May 2010, so it's been a while. So the WHO has already launched this health promoting workplace action process design. So I don't have time to explain this. This is a combination. This is not just epidemiology. So this is a mixed method type of study, looking at from both qualitative and quantitative study, because we are looking at understanding the need of the workers as well, not only from the researcher, but also the need from the worker and also from the employer, both employer and the employee. Okay. Okay, so just quickly skip that part in the context of Australia. So for those who don't know Australia, so Australia is not too far away from Indonesia, about 7 hours or 8 hours from Jakarta to Brisbane. So I live here in Brisbane. So Australia is a federal country. So every state, they have their own department in terms of, that whole primary responsibility for occupational health and safety, because of this is a federal type of country. But we also have Commonwealth or federal government, which is located in Canberra. Right, so this is Brisbane here, somewhere here. I'm not sure whether you can see my laser pointer. So it's somewhere here. Okay. So the epidemiological study, so what we're actually doing, so we're looking at to provide the trends. So I can see the trends in Australian context, looking at what are the major occupational health and safety issues in Australia. So as I mentioned earlier, so we need to understand the trends, understand what have been the main issues in the context of occupational health and safety, looking at the workforce trends impacting occupational health and safety, so such as aging workforce, because we are getting older and older, right? Obesity, and also non-standard employment. So this is also important to understand as well, like casual jobs, part-time jobs, etc. So emphasis on workplace-based prevention. Okay, so this is in Australian context, so we focus more on workplace-based prevention. Yeah, and then multidisciplinary nature of occupational health and safety. And this is really important because not only public health and epidemiology, we have occupational medicines and nursing, we have safety engineering, we have industrial hygiene, we have psychology, and also human factors as well. So those professions need to be involved. Time is up, I think. So Australian context, you can also have a look. This is a website. So Safe Work Australia, or SWA, so Safe Work Australia. It is actually clearly mentioned that the core functions of this is, because as I have mentioned earlier, so we are a federal country, so every state, they have their own regulations, but we are trying to harmonize the approach. So through this Safe Work Australia, it's a national policy body, so looking at from different state as well, responsible for developing and maintaining an evidence-based model for work health and safety in Australian context. Okay. You can have a look at this yourself. The website is really, there is also interactive data as well. You can have a look. So the type of industry, type of, injuries, case fatality rate, and etc. Everything is viewable in this website. Okay, so you can have a look at this yourself. Of course, epidemiological data is central to work health and safety performance and reporting. So this is again epidemiological data to provide you with some benchmarking as well, monitoring trend and risks, informing policy and prevention. So I can have a look at this. So the first, you can have a look at this thing. Vehicle incident is the majority of the worker fatalities in 2023, and then the second one is falls from height, being hit by moving objects and etc. So this is something that we can actually have a look and provide some preventions. Lastly, so in Australian context, so we do also have Australian Research Council, which is also work closely with the Work Safety Australia, which is also important to have a look that from each element of research, they need to provide some outcomes, and they need to really make sure what can be quantified in the context of providing some impact from your research or from our research. In this context, for instance, job creations, risk reductions in decision making, and provide some, especially the higher quality workforce. So this is also important as well to make sure that can you actually see my screen? Maybe it's not seeing your screen. Yeah, okay, you can see my screen, right? Okay. Yeah, so this is just another body in Australian context. So we have Australian Research Council like BRIN in Indonesia. So BRIN work together with the Work Safety Australia, something like that. So they provide money. So the Australian Research Council provide money, and the university do the research, and then the result will be provided to the Work Safety Australia. Then they can use it as a resource for policy making process. I think that's all from me, Mas Rubayat. So I will return the microphone back to you. Sorry, I think I.
Okay, thank you, Mr. Febi. Can we give applause to him for the 30-minute we learning about epidemiology? I think it's more benefit if we collecting the data, and then we use it for occupational health and safety, I think. So we go to the next session, that is Q&A. Unfortunately, we have only limited time, maybe not more than 15 minutes. From the committee, I forwarded from, I think from the audience from Zoom meeting, I think, from Mrs. Dr. Nana. Are you still in Zoom meeting, Dr. Nana? Or you just leave the Zoom?
Yes, I am. Sorry, yeah. I have exercise, yeah.
Yes, ma'am. Please,
okay.
Maybe you have a question for Mrs. Gaylin or Mr. Febi. Please, your time.
Wait a minute. Okay. Yes, thank you for the opportunities, and thank you for the excellent lecture for both us. I have two questions. The first for Galen. We know that melatonin will work starting at 10 p.m. How about medical workers in hospital who have night shift from 9 p.m. until 8 p.m.? It is possible that the pineal gland no longer produces melatonin. This will have many side effects. Do you have advice? Thank you. And for Mr. Febi, how many child laborers are there in your country? And what are the effects on their growth and development? Thank you.
Thank you, Dr. Nana. Maybe for the
Sorry, how many? What? Sorry,
yeah.
I didn't get the last one. How
Yeah.
many? What?
Maybe
For your
in
question?
yeah,
Yes.
in
Thank you
Indonesian
so
Okay.
much.
again, maybe
How
Dr.
many
Nana.
child laborers are there in your country?
Oh,
The
child
child
laborers.
laborers, yes.
Oh, okay.
And what the effect on their growth and development? I'm sorry because I am the pediatrician, so I must to know about the health of children. Thank you.
Okay, thank you, Dr. Rana. Can you get the question, Mr. Febi?
Yes, yes.
Yeah, but for the first question, we are going to Ma'am Gaylin. Can you answer for her question, please?
Thank you, doctor, for your question. And you were asking about nurses who would have their shift at 9 p.m. up to 6, 6 or 7 a.m. in the morning, and how that would affect the expression of melatonin. Okay, so what we do know is that depending on the individual's chronotype, the timing of the expression of melatonin is approximately 2 hours before they sleep. So the 10 p.m. is not an absolute timing. Okay? The thing is, if they are going to do graveyard shift or night shift, of course, their body would naturally at that time be expressing melatonin, but they are constrained by their shift work routine to keep being awake. Okay, so the experience of being sleepy at work when you are doing night work would be natural experience of a diurnal individual, if especially if they're just starting the shift routine. If they as long as they stay in that shift routine, there's a tendency for the individual to adapt. In theory, the adaptation means that supposedly your melatonin expression is dampened, if not delayed. But what we do know from studies is that shift workers can persist doing their night routine, but the melatonin expression is maintained. Okay, so it's not only the melatonin expression that will influence wakefulness at night. It may be that other circadian clocks of the body are adjusting and the melatonin is not. And that still allows the worker to keep working at night. So it's like it's not a direct answer to your question, ma'am, but basically we don't really right away suppress melatonin expression when we assume the night work. It can continue, and the adjustment of the other body systems is what will help you persist with night work. Thank you.
Okay, thank you, Ma'am Gaylin. For the second question, going to Mr. Febi.
Yes.
Can you?
Yeah. Thank you so much. I'm not too sure about the current data in terms of the child laborers in Australia, but Australia has a very strict regulation in terms of child laborers. If I'm not mistaken, here in Queensland, so because as I said, so a different state might have different regulation in this aspect, but I think this one is quite clear that at least you need to be 13 years old. This is considered as this is like a school age, children. They can start working, but this has to be a very in a very specific environment. Like mostly they start learning how to get money, but they need to get permission from the parents, they need to get permission from the school. Yeah, so which means the student or the children need to be at school, right? So they need to get permission from the school. So let's say they just do it on weekend or maybe after the school hours and etc. So it's very strict, right? So you need to be at least 13, so to be working in a like a fast food retailers like McDonald's, KFC, Hungry Jacks, and etc. So there are also certain regulation as well in terms of the time, like how many hours and etc. The workplace has to be child friendly as well. Okay, so they cannot be working in a bar or in a something like a pub or something like that. So where involved, where there's alcohol and etc. So they are not allowed to be working in that kind of environment. and also, of course, not allowed to be working in industry, factory that has, a lot of occupational hazard, etc. But here in Australia, I think a lot of kids, they also working as a, like from 12 years old, 11 years old as a newspaper. They just they just throw newspaper to your house, things like that. So as a, just to get some pocket money. But I think other than that, it's not as similar to what happened in other countries, especially in Indonesia, because we just finished a project together funded by DFAT in Semarang, in North Jakarta, in Pekalongan, in Demak as well, working together with Diponegoro University. So hopefully in the future we can work with UMM as well in this regard. So looking at child labors in coastal communities. And then some of them, they skip schools, because, and this is also what they were saying. So if the children, if they know money, kalau sudah tahu uang, so they will not go back to school because they, why I have to go to school? Because I can earn money. So this is something that we don't want to happen, right? So through that research, back again in Demak, Pekalongan, Semarang. So basically, we want to make sure that child labor, and especially those who are working in the market, those who are helping their parents, do some labors, stuff, and hopefully they still can finish their school as well. So, but I don't know in terms of, you mentioned about the statistic, so I don't have that information at the moment. Yes.
Okay. Yeah. Okay. Thank you for the answer, Ma'am Gaylin, and then Mr. Baby. Now I give the opportunities to my student. I think I only have 3 students to ask 3 questions because of the limited time. But I also have 10 voucher here, and then 2 goodie bags from the committee. So please, can you help me, the committees, to give the opportunity to the audience? Yeah, please. I
If
need
if your student come to Australia, we'll give you coffee voucher as well.
Okay.
Excuse me, Dr. Rubaya.
I'm sorry.
Excuse me, Dr.
Wait.
Rubaya.
Yeah. Yes, ma'am. Yes, Dr. Nana.
I ask one question, just one question for Mr. Febi. Are there any penalties for companies that employ the children in your country, in Australia?
Yeah. Yes, of course, and it's a huge penalty. Even just to give you an example, like for instance, this is very strict. Like to buy tobacco, to buy cigarettes, so there's a certain age limit, right? So if there's an evidence that you break or you breach these regulations, there's a lot of you need to pay a lot of money. And the worst case will be your business will be closed, and you have to stay in prison as well for quite some time. So it's a very strict regulation in terms of child labor.
Close the companies. Okay.
Yeah,
That's
it's a very
great.
tough
That's
regulation.
great. Okay. Thank you.
Okay. Thank you very much, Dr. Nana. Yeah. Okay. One, and then the second. And then the third, please, the committee, give the microphone to them. Number 1 is, I think, in the middle, and then the second on my right side. The third is on the behind. The first question, maybe? Can you say your name, your affiliation, and go on to your one question only, yeah? One question.
Okay, thank you for the opportunity. My name is Daniela, and my question is for Ma'am Manalang. From the chart you shown on your presentation, fragmented sleep only happen during night. And is it possible for people that have shift or nocturnal people will have fragmented sleep when they napping in the noon or at the day? Thank you.
Thank you, Ms. Daniela, for your question. That's even a rarer phenomenon, I think, maybe even unexplored, if nocturnal individuals and shift workers have fragmented sleep. I would say there is more evidence on the latter about shift workers. If coming off the night shift during the day, their sleep environment is not promotive of sleep. it's likely that they will have fragmented sleep. So let's say if it's like where we are, during the daytime it's very bright and you don't have light blocking um, curtains. Maybe there are other goings on at home because you share a home with other people, then very likely you won't be able to sleep well. Now, for the nocturnals, the real nocturnals, if they have fragmented sleep, uh, I have not encountered any literature about that, but likely it might be, in theory, also an experience of the nocturnals. It because the phenomenon is genetic. Okay, so it there is a different gene that dictates whether you're diurnal or nocturnal, and a different one that influences sleep fragmentation. Okay, so interesting question that you brought up. Thank you.
Thank
One
you.
voucher for you.
Okay, I will give one voucher from Mom Gailin and
Two
then
for me.
Two. Yes, for you is unlimited, Mom. Okay, for the second audience, please say your name and then go to your question.
Okay, as before, good afternoon, everyone. My name is Rosa from batch 22. And I would like to ask to Mr. Fabi. And as we know, epidemiology is very important for various studies aimed at advancing knowledge in the field of occupational health. Sometimes epidemiological research at company is prohibited by the lack of permission from the company itself. So in your opinion, what kind of concrete communication would make company willing to grant research permission while reducing their concern about confidentiality, employees' physique, or maybe employees' mental health?
Okay.
Thank
What's
you.
your name? Sorry.
Rosa.
Rosa.
Yeah,
Okay,
thank you.
Miss Rosa. Mr. Fabi, can you directly
Yes.
answer the question? Yeah, please.
Now, this is a very important questions and very great that you bring these questions in these discussions, and it is pretty much depending on the situations. To be honest, here in Australian context, there has to be an openness by all factories, industry, if there's any, especially if there's any disease outbreaks, if there's any occupational disease that happen in that particular factory or industry or offices and etc. So there has to be an openness, as I have mentioned earlier in Safe Work Australia in that website. So accountability and transparency is the key, and it is it is by law, so they have to provide that, data to the authority to provide some investigations. So I think what you were saying, I think it's more about like student research or maybe dissertations like PhD studies. If they want to conduct research in a factory or industry, so that's a bit different story. So of course, you need to get ethical. The ethic has to be approved by the university. They need to show to the industry. So basically, you need to convince that you need to convince them that what you're doing is not about exposing what just happened in the factory, but it's more about how to make their performance even better in the future. So if you still remember in the presentation that I put in one of the slides is about that if there is any if we can create a healthy promoting workplace, then that particular factory or industry will actually perform more. So so you need to talk about, because sometimes business owner or the company, the leader of the company, they will let you in if you're talking about money. If you're talking about like, look, if you conduct this research and then if we do something about this, your workers will feel happier and they will perform more, and we can produce more, or you can produce more, and then you can actually become better company in the future. So by doing this, convincing that this research is not about like exposing what bad things they have in their company, I think they will agree. But of course, policy, support is very important. Political support from the governor, from the head of department is also very important before you conduct research, right? So, and then hopefully by showing that, look, I got this support, I got this endorsement from this, head of department, or the leader of this regional setting. So potentially they will open the door for you to conduct research. But it's not an easy answer, because potentially maybe they hide something, So, but I would actually say if they actually close the door for any research, maybe they are hiding something. They're hiding something so that they don't want other people to know. So, itu Mbak Rosa, hopefully I can answer your questions. But that's my response to your questions. Thank you.
Thank you, Mr. Feby.
Okay.
Thank you.
Okay. For the next question, I think last two question maybe I asked by our committee. I should have one question after this is the last part. Doctor, please raise your hand. Please stand up, and please the committee give the microphone to her. And then the last question from my left side. Yeah.
Baik, Assalamualaikum warahmatullahi wabarakatuh. Perkenalkan, saya dengan Sefayahi Ayuning Vinosa dari Angkatan 2022. Terima kasih untuk kesempatannya. Mohon izin dokter. Thank you, Dr. Manalang, for your valuable insight on sleep ergonomics. May I ask a question about how your recommendation can be implemented? Given the evidence that long working hours harm health and productivity, why have labor regulation and not set stricter limits on shift duration and rest? And are there any solution can be offered for this issue? Thank you.
Okay, so thank you for your question. I'll try to answer as best as I can because it has a lot of dimensions. First, on the aspect of regulation, if you have different industries that pursue shift working, you will not be able to, I guess, implement a one-size-fits-all policy because the scheduling in shift working is dictated by demand for the product or the service that the industry makes. So the solution would be a policy that is instructive enough for the industries to pursue a program for their shift workers, but shall we say liberal enough for them to create the appropriate components. Okay? So the components that would be in the program would include something about awareness, about shift working in the health sense, and also enhancing the typical health examination to include assessment of sleep timing and other sleep-related parameters. This is crucial for shift workers because we may be clinically giving them advice about, let's say, taking melatonin, for example, to promote sleep. But depending on your chronotype and when you take the melatonin, the effects would be different from body to body. Okay, so in the Philippines, melatonin is an over-the-counter medication or drug. It's actually considered a supplement. But in the United States, it's can only taken with a prescription. So the program should recognize that there are specific individuals, or there should be an individualized approach when you recommend such medical intervention. Then also to empower workers so that they protect their rest time. Okay, so it's making them aware that there are behaviors that are going to help them at work, but they do it at home. Okay, so examples. If you're going off shift work, okay, it's best that you head straight home and take advantage of the full time of your break. Okay, instead of maybe right away doing socialization after work, it's best that you go home and rest. There's also advice, for example, about timing when you are exposed to natural light. Okay? So the literature tells us that if we consistently are exposed to natural light in the morning, the effect of that will be advancing the sleep start. But if you consistently expose yourself to natural light later in the day, like in the afternoon, the effect of that would be delaying your sleep. Okay, so if workers are aware of such manageable self management behaviors, they can prepare themselves better for shift working. Okay, so yeah, so many dimensions of your question on regulation, on at industry, what is needed and what workers need to be aware about. Maybe I'll end by saying that if you have someone who has shift work related disorder, is not always needed or not necessarily managed medically. It might have to do with behavioral intervention and even environmental modification. Okay?
Okay,
Did I
enough?
satisfy your question? I hope so.
Okay, thank you for
Thank
your
you.
question and your answer, ma'am. And then for last but not least, may I give the last chance before we close this session. Please, the committee, give the microphone to her. And then please say your name and then your questions. Any trouble in microphone problem?
Oke, Assalamualaikum warahmatullahi wabarakatuh. Good afternoon, everyone. Let me introduce myself. My name is Diana Naresa Putri. So I have question for Mr. Febi. So my question is, in Indonesia, many workers in informal sectors, such as farmer, fishermen, and etc., are often not recorded in the formal occupation health system. How can epidemiological approach be adapted to gather accurate data from this group, and how can such as data then be transformed into occupational health solutions that are not only effective but also aligned with local culture, values, and resource limitation in Indonesia? That's all. Thank you.
Thank you so much. That is a very difficult questions to answer, to be honest. Um, as I have mentioned earlier, so I think data is the eyes for policymakers, and I do understand that in Indonesian context we have a lot of informal sectors, and they have no recording, they have no data at all, right? So that's why when we did our study, going back again to the story when I mentioned that we had a collaboration study with Diponegoro University in Demak, Pekalongan, Semarang. So we involve fishermen, and they don't have any BPJS as well. They have no insurance like as a fisherman. So you can imagine like if you're working in a place where there is no insurance, so if something happened, then you won't be covered by anything, right? So this is not right. So we raised this issue as well. Basically with this one, I forgot what is your name, but it is very important. It is our role to make sure that they are covered, right? So these people, they are working, they're trying to find money to put food into the table for their family. So basically they are working, right? They are doing something legal as a fisherman. This, however, there is no certain regulations that provide protection for them. So we need to make some advocacy. So as part of our jobs as well, as an epidemiology or public health researcher or medical professional, we need to provide some advocacy for these people as well, because they are more affordable compared to people who are working in a place where they have insurance regulations and etc. So yes, so that is basically something that we can do. And then after that, of course, data collections reporting has to be done. But then, of course, the first thing that we need to make sure is that equality has to be there, right? So they have to remember about the thing that I mentioned earlier, health is human rights, but people who are working as fishermen, they have no access to, you know, for instance, insurance. So what happened, right? So maybe I will end my answer with that thing. So we need to do advocacy. So that's the only thing we can do. Otherwise, if data is not available, then it is difficult for us to conduct research. Thank you.
Thank you, Mr. Febi. Maybe we can give applause to all of the answer from our speakers. And now the last part, as I promised to you, I invite you to the stage. The four audience, please going down and then go to the stage. I will give you the first two question, goodie bag, and also I mentioned five of you that the first five attends in this meeting, in this conference. Yeah. Mega Anugrah Utami, where is she? Mega, you can go to the stage. Mega Elvira Lisa Wibowo, Jaya Ananda Devi Pitaloka, Putri Maulidatin, Rosalia Dwi Permatasari. I'm sure your main motivation is about this voucher. You can drink coffee as much as you can. Okay. Please, ayo silakan ke panggung ya. Silakan berdiri berjajar. And please, Ma'am Gelin, can you give the goodie bag first, and then the last is on the voucher. Ya. Yuk, baris yang dua. Dua siapa tadi? Daniela. Ya. Yes. Yes, yes, one photo. Rosa. So another question, another audience, please. Ayo cepat. Time is up. Time is running up. Don't you want to accept this voucher?
But we have them on this side.
Ah, okay. Okay, how many of you? Four? Just four? I think 2 tambah 5, 7, 7. Mega, and then Elvira, baris ya, biar. Mega, Elvira, Dea Ananda, Putri Maulidatin, okay, Rosalia. What about another question? Ayu, ya. Yeah. Oh, okay, sorry. Oh, okay. Kurang satu ya di sebelah kiri tadi ya. Oh, okay, ya. Ya, kurang tengah. Ya. Oke. Ya, oke. 2, 3, 4, 5, 6, 7. Oke. Ma'am, please, you. Can you give the voucher, ma'am, to one of them? Only one, ma'am, yes. Only one, yes. Only one. The rest is for Mr. Fabi, I think. Okay, let's have the photo. Agak mepet situ.
Dr. Febi, smile.
Okay, I'm smiling too. I'm sorry, maybe you can see me.
Okay, thank you. You can go back to your seat. And this is the last part, the last session before going back to the MC. And then I once again say thank you very much to Ma'am Gaylin, to Mr. Febi, that your expertise, your learning session, your slide is, I think it's very wonderful, and it's very benefit for especially our students. And then for the question, I also give appreciation on behalf of the committee. Thank you for your question, and thank you for your answer, Ma'am Gaylin and Mr. Febi. I think it is interesting for us to have a further collaboration between UMM and then I think Griffith University and also UP Manila, ma'am, to have the future. Maybe we can have collaboration about the research on ergonomic, on sleeping disorder, I think, and then for occupational health, and then for the sites of the epidemiological expertise from Mr. Febi. I hope so that UMM is going more international style, I think. Yeah. So I think that's it for the session. Thank you, and alhamdulillahirrahmanirrahim. I close this session. Wassalamualaikum warahmatullahi wabarakatuh. Going back to MC. Okay, thank you.
Thank you so much. Thank you.
Okay, thank you to Dr. Hidayat Indradi MI as a moderator. Also to the speakers too, great speakers today. Please give applause, guys. Okay, before we end the session, we have handover to the souvenirs. Next is handover the souvenirs to Ms. Gaylin, and that will be handed by Dr. Anissa Nurul Arifah, SPMB unit, to go to the stage, please. And also we invite Dr. Hidayat Indradi MOH to go to the stage. Okay, once again give applause to Ma'am as a great speakers today. Also to the Mr. Fadi Brianamadi PhD, thank you. Okay, and the last session in this conference, we have a photo session with all the audience and all the audience. Stand up please, and we invite Dr. Febri Indra Budi Setiawan to have a photo session together with all the audience. And also we invite the lecturer and the committee, Dr. Anissa Hanifah. Okay, once again, all the audiences, please stand up. We will have a photo session with the great speakers and with the lecturer and the committee. Oke, pertama kita foto formal dulu ya. Untuk semuanya, mohon izin untuk bisa dapat melihat kamera semuanya. Jangan lupa tersenyum. 1, 2, 3. Oke, sekali lagi. 1, 2, 3. And the last, boleh gaya bebas? Oke, sudah siap semuanya? Jangan lupa lihat ke kamera. 1, 2, 3. Okay, thank you. Have a seat, please. Well, thank you to the lecturer, the committee, and also the speakers today. And well, thank you for all to the audiences. I hope you enjoyed the enlightening presentation and discussion today. But before we end this conference, we have announced the best paper. In this conference, we have announced best paper, and please be kind to announce best paper to Miss Gaylan Manalang GR to announce give a best paper in this conference.
This is the award for the best article, and it's my honor to call out the second prize first. Do you have a feeling that it's your paper? Okay, so the reasoning for the second prize is that it's original anthropometric forensic relevance and shows good initiative in linking anatomy to practical applications, as well as demonstrating in the paper strong methodological and conceptual characteristics. Let's put our hands together for the author of the article, Estimation of Height Based on Femur Length, Measurement in Young Adults of Javanese Ethnicity. Our second best article is Dr. Anung Putri, MSI. We request you to come on stage. Am I right? Please come on stage to be recognized. Coffee voucher. Okay, this paper is a collaboration of Dr. Anong's student also. Please clap for them for their work. Thank you. Okay, there. Okay, thank you. So that's their certificate, and they have a voucher also for coffee. I want photo with them. Because I will suddenly have hosting duty. Thank you.
Thank you for Mrs. Gaylan GR, and also to congratulations for Dr. Anung Putri Ilahika MSc for the best article. Oh, the second best article in this conference. Okay, and the next is the first winner on a best article in this conference. Okay, Mrs. Gaylan will be announced.
Interesting. Okay, for this our article is recognized as the best article of the conference and to be given the first prize. The reason is that with the evaluation of the judges, there's clear and relevant clinical occupational health focus demonstrated in the paper. The paper also used validated tools, the Pittsburgh Sleep Quality Index, and well, the other tool I'm not familiar with, the OSDI. Lastly, they demonstrated in their work structured and strong methodology. I'm so happy to read the title of the study, and it's related to sleep. please let us recognize for the first prize the work, sleep quality, and dry eye disease symptoms in shift workers at Muhammadiyah University Hospital. Is it related? And this is the work of Dr. Aryani Vindya Putri, SPM, MMRS. You have collaborator with the study, ma'am? Not yet. Okay. Not here. All the vouchers are hers. Congratulations,
Thank you very much.
Let's take photo.
Okay, once again, thank you to Mrs. Gala Melana GL for announcing the best article, and congratulations to Dr. Aryani Vidya Putri, SPM MMRS, as a first best article in this conference. And well, thank you for all audiences. I hope you enjoyed the enlightening presentation and discussion today. And I will remember that at 1 p.m. we have oral presentation. Oral presentation tepatnya ada di lantai 7 di ruang skill. Jadi teman-teman nanti setelah naik lift bisa langsung keluar dari lift, belok ke kanan. Ada di ruang skill. Teman-teman yang akan mengikuti oral presentation silahkan untuk bisa hadir tepat waktu, tepat pukul 1. And please come on time and enjoy the class. Thank you for all presentation today. And wassalamualaikum warahmatullahi wabarakatuh.